Okay, so picture this. You're the first one at the scene of an accident. Sirens wail in the distance, could be a fender bender, could be something way worse, You've got one shot to make the right call to stabilize things before it's too late, and that is where ATLS comes in.
Your crash course in trauma care.
Exactly. And we're diving deep into the ATLS 10th edition student manual to bring you, the crash course on the crash course.
This is the globally recognized gold standard for handling these high-stakes situations.
Right, but we're not talking about memorizing every single step. This deep dive is about really understanding the why behind those life-saving actions. It's about the system as a whole.
And what's fascinating is that this whole system, this globally recognized protocol, started with a group of doctors in Nebraska.
Really?
Yeah, they just wanted to improve trauma care in their own backyard, so to speak.
It's almost like a textbook case of think globally, act locally, but in reverse.
Exactly. It's a remarkable story. What started as this local course in Nebraska quickly gained traction, and for good reason. The system they created, it worked.
And it's interesting you say that, because one of the big things the manual emphasizes is this move toward what they call inclusive trauma systems. What exactly does that mean?
So imagine a world where a small community hospital, say in rural Montana, is equipped to handle a serious trauma case, to stabilize the patient, provide that initial life-saving care.
While a specialized trauma center hundreds of miles away gets ready for their arrival.
Precisely. It recognizes that not every hospital can be a level 1 trauma center, right? Not every place has all the resources. But every single hospital, big or small, has a part to play.
That makes a lot of sense. But to maintain a system like that, where hospitals big and small are all working together, that takes incredible coordination. And let's be honest, resources.
Oh, absolutely. It's a constant challenge, especially when it comes to things like securing funding and just raising awareness about trauma as a serious public health issue.
Okay, so we've got these inclusive trauma systems, hospitals big and small, ready to play their part. But what about the actual process? Like, what happens when ATLS swings into action?
Well, the ATLS manual breaks it down into these phases, and it's actually a pretty fascinating journey, starting even before the patient gets to the hospital.
Oh, you mean like the pre-hospital phase?
Exactly. And this phase can make or break the whole thing.
Yeah, it's easy to think of it as just get the patient to the hospital ASAP, but the manual really digs into how those first responders, the paramedics and EMTs, are absolutely vital.
They're essentially taking the emergency room on the road, right? It's not just driving an ambulance. They're triaging, stabilizing, even potentially calling the hospital with key details so the team's ready.
Oh, so they can prep for the patient's arrival.
Precisely. And minimizing that scene time, how long it takes to assess, stabilize, transport, that's often what makes all the difference.
And then what? The patient arrives at the ER, and I imagine that's when things get really intense.
It's definitely high pressure. That's where the ATLS primary survey comes in. It's all about rapid assessment and prioritization. We're talking ABCDEs here: airway, breathing, circulation, disability, and exposure/environment. Each one is crucial, but the order matters.
So it's not just a checklist, it's like a prioritized checklist, because some things are more immediately life-threatening.
Exactly.
Yeah.
Let's say you have a tension pneumothorax, basically a collapsed lung where air is trapped, putting pressure on the heart. That can be fatal in minutes if it's not treated.
Oh, wow, that's serious.
So even before a full head-to-toe exam, the ATLS protocol makes sure that potential tension pneumothorax is addressed right away.
Makes sense. You got to deal with the most urgent thing first. It's just amazing how every detail matters in these situations. Even something like inserting a gastric tube or a urinary catheter, those seem pretty routine, but the manual makes it clear that they're not.
Right, it's all connected. In trauma, a gastric tube isn't just for feeding. It can prevent vomiting and aspiration, which, if a patient has a head injury, could be really dangerous. Same thing with a catheter. It's not just about monitoring urine. It can tell you about internal bleeding and the patient's overall fluid status.
So every action has these ripple effects.
And ATLS helps medical professionals anticipate and manage those effects.
So once the immediate life-threatening stuff is under control, what happens next?
That's when we move to the secondary survey, which is a much more comprehensive head-to-toe examination.
So the primary survey is about finding those big immediate issues. Is the secondary survey about looking for the less obvious but still potentially serious things?
Exactly. Think of it like detective work, right? The secondary survey is about carefully examining the patient from head to toe, making sure nothing was missed in the initial assessment, like hidden fractures, internal bleeding, neurological problems, anything that could cause complications later on.
And this is where that whole concept of continuous monitoring comes in, right?
Absolutely. Even if a patient looks stable, things can change so quickly with trauma. Vital signs can fluctuate, new symptoms might pop up, the patient's condition can deteriorate fast. Continuous monitoring helps the trauma team catch those changes early on.
It's like they're constantly reassessing, reevaluating, making sure they didn't miss anything, looking for any clue, any little detail that could point to a bigger issue.
That's a great way to put it. In trauma care, those small details can literally make the difference between a smooth recovery and a life-altering complication.
Now, I'm sure people are wondering about how ATLS handles different types of injuries. Because a gunshot wound has got to be different from, say, a fall, even if both are traumatic.
Yeah.
You're not going to treat them the same way at all. But that's the thing with ATLS. It gives you this framework for understanding how different mechanisms of injury, like you said, a gunshot versus a fall, can cause really different patterns of damage inside the body.
Yeah, it's like ATLS gives you X-ray vision or something. You can see past the external injuries and kind of anticipate what kind of damage might be going on inside.
So fascinating.
Like with a gunshot wound, for example, it's not just about the bullet itself.
There's more to it.
Oh yeah, it's the velocity, the trajectory, even how the bullet was designed. All of that plays into how much damage it does internally.
So a small caliber bullet at close range, that could actually be worse than a larger one that, say, goes straight through.
Exactly. It all comes down to energy transfer. A bullet going really fast might have a small entry wound, but it creates this like shock wave inside the body, which can cause massive damage to organs and tissues.
Wow.
And that's where ATLS helps so much. It guides medical professionals to anticipate those complications and figure out the best way to treat them.
So it takes a lot of the guesswork out.
You could say that, yeah. It's like a roadmap for assessing and managing trauma based on how the injury happened.
That makes sense.
And this approach, it's not just for gunshot wounds, it goes for all kinds of trauma.
Yeah.
Blunt force trauma, like from car accidents or falls.
Yeah.
Penetrating injuries like stabbings, even blast injuries.
Blast injuries, like from an explosion.
Exactly. Those can be really complex. But ATLS breaks it all down.
That's wild. And I think something that really stuck out to me in the 10th edition is that they emphasize how ATLS isn't just for trauma surgeons, you know?
I think it's for everyone.
Like anyone who might come into contact with a trauma patient.
Exactly.
Yeah.
Nurses, physician assistants, even medical students.
It's about having that basic understanding of trauma care.
Having the tools to make the right call, even if it's just stabilizing the patient until they can get to a specialist. Because those initial actions, those first few minutes, can be so critical.
It's like this universal language for trauma care, so everyone's on the same page, you know? Especially in those really intense situations when things are happening so fast.
100%.
Yeah.
When it's a matter of life or death, that shared understanding can make all the difference.
This has been incredible. It's amazing to see how this system that started with just a few doctors in Nebraska has become the gold standard for trauma care everywhere. It really has the potential to save lives all over the world.
It's pretty remarkable. And it's a testament to the power of a good idea and a dedication to always learning and improving. And of course, to all the healthcare professionals who put in the work day in and day out to provide the best possible care to trauma patients.
Absolutely. So to anyone listening who wants to go even deeper into this world of trauma care, we highly recommend checking out the ATLS 10th edition student manual. We just scratched the surface, and there's so much more to learn.
It's a goldmine of information for sure.
Until next time, everyone, stay safe out there, and remember, knowledge is power, especially when it comes to trauma. Ever had one of those moments, where everything seems to just slow down, like it's all happening in slow motion, sirens, rain, maybe a multi-car collision on the highway, and you pull up and you're the first one there, heart's racing. What's the first thing you even DO?
That's what's so amazing about ATLS,
Right. Advanced trauma life support.
Yeah, it really takes the guesswork out of those critical moments. Gives you a system, like a roadmap for action, even when it feels like everything's gone crazy.
And that roadmap is exactly what we're diving into today. We're using ATLS Essentials by Dr. Atef Ahmed.
Good book.
To give you all the core principles, even if you never actually, pick up the textbook itself.
And the great thing is, it's not just for trauma surgeons. Dr. Ahmed really emphasizes that. It's for every single person in that whole chain of survival.
EMTs, nurses.
Yep. Everyone working together, like, almost like a well-rehearsed orchestra.
I like that. So let's break this down. Dr. Ahmed, he starts off chapter 1 with, well, preparation, triage, that initial assessment, the ABCDEs.
The essentials.
Right. Seems pretty straightforward on paper, you know? But I imagine when you're in a real trauma situation.
Oh, it's a whole different ballgame. The pressure's on.
Totally. So preparation, that has to start way before you even get to the hospital, right?
Exactly. It's about having the right equipment ready to go, knowing your team, what everyone's role is, and constantly practicing, refining those skills. Dr. Ahmed, he gives this example. Imagine you roll up on a scene, multiple casualties, maybe a bus accident or something. And it's not just about treating the person with the most serious injuries first.
Oh, wow. Okay.
It's about making sure everything you do helps the most people possible.
Triage. No, it's a tough reality of mass casualty situations.
Yeah.
Dr. Ahmed doesn't sugarcoat that at all.
No, not at all. And then once you're at the hospital, that's where those ABCDEs really come in. Airway, breathing, circulation, disability exposure. It's systematic. Make sure you're not missing anything life-threatening in those first few minutes.
You mentioned earlier needle decompression. For attention pneumothorax, Dr. Ahmed, he points out that even paramedics are trained to do that now.
Yep. It can be that time sensitive.
Wow.
Really highlights how ATLS wants everyone to have those life-saving skills.
Absolutely. So the patient is breathing. We've bought ourselves some time. But what about blood loss? I mean, Dr. Ahmed really stresses how vital that circulation assessment is.
He does. And it's not just blood loss. We're talking about shock, too. Hemorrhagic, cardiogenic, obstructive. There's more than one way the body can go into shock. Dr. Ahmed's really clear about that. Each type needs a different approach.
So it's not as easy as just looking for bleeding.
Right.
You have to look at skin color. Are they clearly confused? All those little clues, like you're piecing together a puzzle.
Right.
In the middle of a crisis.
Exactly. And then there's D, disability. Got to do a quick neurological assessment. Are they alert? Responding to questions. That kind of thing helps you figure out, 1, if there's a head injury, and 2, how bad it might be.
And finally, E, exposure. That one seems, I don't know, self-explanatory, get those clothes off. But Dr. Ahmed points out that it's about more than just that, right?
Way more. It's about preventing hypothermia, which, for a trauma patient, can be a huge problem.
Even if it's not, like, freezing cold out.
Even then. Their bodies are working overtime already. They're vulnerable to temperature changes. Even a little drop can make bleeding worse and lead to other complications.
So we're talking warmed blankets, warmed IV fluids, all those little things that could easily get missed when things are intense.
You got it. It's about maintaining that balance. Now, all that, the initial assessment, those ABCDEs, that's just the start. Dr. Ahmed goes into a lot of detail about other things we can use to paint a clearer picture. ECGs, X-rays, fast exams.
He's a big proponent of fast exams, isn't he? Focused assessment with sonography for trauma, he calls them a game changer, especially when it comes to abdominal injuries. What makes them so important?
Speed. With a fast exam, you can see if there's free fluid in the abdomen. That's a major indicator of internal bleeding, and you can find it right there at the bedside.
So it's all about connecting the dots,
right?
Using every tool you've got to figure out the injuries and prioritize treatment.
You got it. Eliminate the guesswork. Give the patient the best possible chance.
Okay, so we've got the groundwork laid. We know those crucial initial steps of ATLS. That's what happens in those first few minutes after an injury. But what about specific types of injuries? How do you use these principles when you're really in the thick of it, you know, in trauma care?
Now, that is where things get really interesting. And that's what we're going to get into next.
Okay, so we're back and ready to really get into the specifics of managing trauma. Using ATLS, of course. And let's start with something I think we've all experienced at some point.
Everyone's had a bump on the head.
Exactly. So a knock on the head.
Seems simple enough, right?
Yeah.
But, as Dr. Ahmed points out in Chapter 6, even what seems like a really minor head injury can have some pretty big consequences.
So what are some of the most important things that, ATLS teaches us about, first of all, assessing a head injury? And then how do we manage it? Because obviously it's more than just how many fingers am I holding up?
It is. It really starts with understanding the anatomy, how the brain is protected inside the skull, and any kind of swelling, any bleeding in that space, that's where things get dangerous really quickly. Intracranial pressure, ICP.
Right. And Dr. Ahmed, he talks about how the body tries to compensate when that pressure starts building up, but there's only so much it can do. So what are some of those, warning signs? How do you know if things are going downhill?
The early signs can be kind of sneaky, maybe a little confusion, some nausea, change in breathing. But if that pressure keeps building, you might see a really bad headache, vomiting, even a coma.
So you really have to catch it early.
Absolutely.
What can you actually do about it, though? Like, how do you manage rising ICP?
ATLS takes a multi-pronged approach. First things first, you've got to make sure the airway is clear. And then you've got to keep that blood pressure stable. Medications to reduce swelling are key, too. And in the worst-case scenario, surgery might be the only way to actually relieve the pressure.
I think Dr. Ahmed even mentions, like, a procedure where they'll remove part of the skull.
Craniectomy.
Yeah.
To give the brain room to swell.
Wow. Intense.
It's a last resort for sure.
It shows how serious head injuries can be. Okay, well, speaking of serious, let's talk about spinal injuries. Because, I mean, that's another area where, one wrong move.
Huge consequences.
Absolutely. Dr. Ahmed, he dedicates a whole chapter to this in the book. So what are the biggest things to keep in mind when you're approaching a potential spinal injury?
Immobilization. That is absolutely key. And I mean, from the second those first responders get to the scene, all the way through transport, initial evaluation, you've got to protect that spinal cord from any more damage.
That makes sense. But I know there's been, some debate about using backboards and neck braces. Is there any risk of making things worse?
It's a good question. And the guidelines have changed over the years because of it. But, like Dr. Ahmed says, it's always better to be safe than sorry.
Err on the side of caution.
Especially in those first few minutes.
So, okay, let's say you've stabilized the spine as much as you can at that point. How do you actually figure out how bad the injury is?
You need a really, really thorough neurological exam. You're checking for sensation, motor function, reflexes. Basically, we're trying to map out what's working and what's not.
Right.
Imaging CT scans in particular, those help us actually visualize the bones, the spinal cord.
The big question, obviously, is whether there's any damage to the spinal cord itself. Yeah. Dr. Ahmed describes it as like the information highway between the brain and the rest of the body.
Love that analogy. And when there's damage to that highway, well, the effects can be, they can be all over the map, literally, from weakness, numbness, all the way to paralysis.
So managing a spinal cord injury, I'm guessing that's a long and complicated process.
It can be. It often takes a whole team of specialists, surgeons, neurologists, rehab specialists, everyone working together to get that patient back on their feet.
There's that teamwork again.
Always crucial.
Dr. Ahmed mentions that even something as simple as knowing, who's who on the team,
their roles, yeah,
can be crucial in that moment when things are crazy. Kind of like we were saying earlier, like a well-rehearsed orchestra.
Exactly. Everyone knows their part.
Okay. We've done the head, the spine. What about the chest?
Another vital area.
Yeah. Dr. Ahmed really drives home the point that, well, obviously, it houses some pretty important organs.
The heart, the lungs, yeah.
So A and Y injury there has to be taken seriously.
No doubt. And we're not just talking about, bruised ribs or anything, though those can be painful. But we're talking injuries that can affect your ability to breathe, to get enough oxygen to circulate your blood.
Like a tension pneumothorax.
Exactly. Or a massive hemothorax where you've got blood filling up the space around the lungs.
And that's where, again, it becomes all about time.
Every second counts.
Wow. Okay, so what needs to happen?
You got to be fast. Assess the situation, needle decompression if needed, chest tubes. These are all things that can absolutely save a life. And sometimes surgery is the only option if there are organs that need repair.
Dr. Ahmed also talks about rib fractures. He makes a really good point about how dangerous those can actually be, especially in older adults.
Yeah, it's easy to think of rib fractures like, okay, you broke a rib, it'll heal. But when it's an older patient,
it's different.
Very different. First of all, their bones are just more fragile, and they're more likely to have other health problems that complicate things.
So you're saying like a rib fracture that a younger person might just kind of shake off, for an older adult, that could actually be life-threatening?
It's possible. Yeah. They might not be able to take a deep breath because it hurts so much. And that can lead to pneumonia. That's why good pain management is so, so important.
It just goes to show you there's always more than meets the eye with this stuff.
Always. Trauma care is not one size fits all.
It's really not.
No.
Okay. Anything else on chest injuries?
Well, Dr. Ahmed also talks about blunt cardiac injury.
Which is?
Damage to the heart, but from like a forceful impact.
Yeah.
A car accident, a blow to the chest.
And that can really mess things up.
Big time. And the problem is, it can be hard to diagnose because the symptoms aren't always super obvious, but it can be really dangerous if you miss it.
So how do you even catch that?
You have to be really suspicious. If you've got any patient who's had any kind of significant blunt force trauma to the chest, you have to do a thorough cardiac assessment. EKGs, echocardiograms to make sure there's no damage.
And then treatment. I'm guessing that depends on the injury.
It does. Everything from medication to stabilize their heart rhythm all the way to surgery.
So we've gone from head to chest, and we're seeing this pattern, right? ATLS provides this system, this framework for taking action, no matter the injury. So what's next? Where are we going next on our deep dive into ATLS?
Let's talk about the abdomen. Talk about a place packed with vital organs.
And every single one of them can be injured in a trauma situation.
Exactly. And each one with its own vulnerabilities.
All right, so we are back, and we are still making our way through the world of ATLS. We've done the head, the spine, the chest.
A lot of organs to cover.
So many organs. And I know we said this is like a puzzle, but what are we talking about with abdominal injuries?
Well, if you think about it, the abdomen, it's almost like a suitcase, right?
Okay, I see where you're going with this.
Packed full of all these really important things, but there's not a lot of extra space. And Dr. Ahmed points this out in Chapter 5. He really does, he says, with abdominal trauma, what you see is not always what you get.
Meaning, the worst injuries, they don't always have the most obvious symptoms.
Not necessarily, no. So you can't get complacent. You've really got to be paying attention during that physical exam.
And the FAST exams, we talked about those earlier.
Yep. They're really important here, too.
Because you can see if there's internal bleeding.
Exactly.
Yeah.
Free fluid in the abdomen, that's a big red flag. And depending on the mechanism of injury, what else you're seeing on the exam, you might need more imaging. A CT scan, x-rays.
Dr. Ahmed, he even mentioned something called diagnostic peritoneal lavage.
Yeah, that one's a little more old school.
But still important.
In certain situations, yeah. Basically, we're talking about putting a needle directly into the abdominal cavity to see if there's blood in there or other fluids.
Okay, so that definitely sounds like a more invasive kind of procedure.
It is. It's not the first thing we'd do, that's for sure.
Okay, so let's say you find something serious, like there's bleeding, an organ is ruptured. What happens then?
Then you go back to your ATLS training. Those core principles. Stabilize the patient and get them definitive care as fast as possible. So we're talking controlling that bleeding, making sure their vital signs are good, and if they need surgery, we get them into the OR now.
It's kind of amazing though, right? ATLS really gives you that framework, no matter what the specific injury is. But, Dr. Ahmed also talks about special populations, and it's a good reminder that trauma, well, it affects everyone a little differently.
Huge point. Kids, older adults, pregnant women, they all have unique physiology that you really have to consider when you're managing their care.
Let's start with the youngest patients, because, treating a child who's been injured.
Talk about high stakes.
Right. It's a completely different ballgame.
And Dr. Ahmed is very clear about this. He says, and this is a direct quote, children are not just small adults.
And he's right.
Their bodies are still growing. Their bones are more flexible. Even the way they respond to medications, it's all different.
So when we're talking about children, what are some of those key differences in the ATLS approach?
Honestly, everything has to be adjusted. Everything from managing that airway to giving them fluids. It's all based on their size and how far along they are developmentally. For example, their airways are smaller, way more prone to getting blocked. So we have to be extra careful with intubation.
Wow. It makes you realize how specialized this field really is.
It is.
And then, of course, you have older adults, which, you were saying earlier how even something as like a simple fall
can be devastating. You're dealing with more brittle bones, organs that aren't as resilient, and chances are they've got other health issues already. It makes things tricky.
Dr. Ahmed gives an example, right, of an older patient who fell, fractured a rib.
Yep, and you're thinking, okay, fractured rib, painful, but
manageable.
Right, but this particular patient, because of her age and because she had heart condition, she wasn't able to breathe deeply enough because it hurt too much.
Oh, wow.
Which led to pneumonia. And she ended up in the ICU.
It's heartbreaking. But it really shows why it's so important to think about the whole picture. The big picture. You can't just look at the immediate injury. You have to think long-term with older adults.
Think about those potential complications. Absolutely.
And that kind of brings us to another patient population where that kind of thinking is critical. Pregnant women. And Dr. Ahmed, he does not shy away from...
How complicated it can be.
Exactly. I mean, you're essentially treating two patients at the same time.
Exactly. And you have to factor in those physiological changes that happen during pregnancy. How's mom doing? How's the baby doing? It can be a lot to juggle.
So are there specific ATLS guidelines for when you're dealing with a pregnant trauma patient?
Absolutely. Fetal monitoring is standard, and the way we position her on the table during exams, during procedures that might be different too, to avoid putting pressure on any major blood vessels.
Right.
Even something as basic as like giving her fluids through an IV, we might have to adjust that because she has more blood volume now.
It's really amazing. I mean, there is so much nuance to this. It's not enough to just know the steps. You have to be able to change those steps based on the patient, how old they are, what other health problems are going on, all of it.
And that's what's so great about ATLS, right? It's not just a list of rules. It's a framework. It's a system that helps you make good decisions in those moments when it really matters.
No matter what craziness is thrown at you.
Exactly.
This has been incredible.
I'm glad to be here.
Honestly, I mean, this whole deep dive, it's really been eye-opening. I want to give a huge, huge thank you to our expert for walking us through all of this complicated stuff. And to our listeners, thank you so much for joining us on this journey. And until next time, we'll see you on the next deep dive.
Ever find yourself wondering how trauma surgeons, how do they make those split-second decisions? Like life or death in their hands.
Yeah.
It's incredible. So we are diving into trauma surgery questions and answers.
Okay.
By Dr. Atef Ahmed. And let me tell you, this guy, he knows his stuff.
Yeah.
Really clear explanations, even though this book, get this, is from 2050.
Interesting. Yeah, it's really something how this book, it's speaking from the future, but the core stuff, the core techniques, they haven't changed that much, have they?
No, they haven't.
It's still about saving lives.
It's like he's giving us a peek into the future of trauma care.
Right.
But through today's lens. And this Q&A format, genius.
Oh, it's brilliant. It's like, when a surgeon's in a life or death situation, they don't have time to read a textbook. They need answers and fast, this format. It just clicks.
It does.
Practical and engaging. Even if you're not a doctor, you get it.
So Dr. Ahmed, he jumps right into it.
Yeah.
The ABCs.
Right.
Airway, breathing, and circulation.
Yeah.
Like we all know are ABCs.
Right.
But in trauma, that's different.
Yeah, it's not elementary stuff anymore, is it? It's a life or death, those ABCs, that's your lifeline. You stabilize them, you buy yourself time, crucial time.
And this is where this book, it sucks you in. For example, he talks about open fractures. And I'm sorry if you're squeamish.
Oh, yeah.
But we're talking bone sticking out, the works.
Yeah, you got to be ready, got to be precise. And Dr. Ahmed, he lays it all out. It's like you're right there in the OR, every step, every move.
It's incredible. He makes it, accessible, even if you're not a surgeon. Then there's this part about Beck's triad. I had to look it up.
Really?
Low blood pressure, neck veins popping.
Yes.
Muffled heart sound. It's like, what? They don't sound like they go together.
But that's just it. That's how you know it's bad. Like a 3-alarm fire, those 3 things. That's cardiac tamponade. Basically fluids crushing the heart.
So the body's sending an SOS.
Yeah.
Beck's triad, it's how to hear it.
Exactly. And if, you connect life or death, This book, it doesn't just tell you, it tells you why. And that is gold.
It's true. It's like connecting the dots. But here's what surprised me. He goes beyond the operating room.
Oh, yeah. Trauma's way bigger than that.
Right.
The thing that blew my mind was how important a seatbelt mark can be.
Wait, so it's not just about, wearing your seatbelt.
It's a clue, right? Dr. Ahmed talks about how that mark, it could mean internal injuries, bad ones. You have to look for those things.
So it's like, you see that mark, you got to think deeper.
Exactly. It's about the big picture.
Right. And speaking of big picture, he has this whole thing on the mangled extremity severity score.
Oh, yeah.
Like, that they'd have to decide if
they got to amputate.
Yeah, tough call.
It's huge, right? You're not just talking about right now. You're talking about their whole life. Dr. Ahmed, he breaks down the score. Like, how bad's the injury? Is the blood flowing? How old are they? Are they healthy? Man.
Heavy stuff.
And you know what gets me? With all this intense stuff, he never forgets it's a person,
Oh, totally. Even in the preface, he talks about saving lives, that feeling, but he's honest, He talks about the pressure, the what ifs.
It's real. Even with all the technology, it's still humans in there.
Absolutely. And he talks about minimizing iatrogenic trauma, which, I gotta be honest, I had to look up.
Yeah, it's a mouthful, isn't it?
It's like The trauma from the treatment itself.
Exactly. You're trying to fix them, but you got to be careful you're not making it worse. It's a balance.
Thinking long-term, not just patching them up.
Exactly. And that kind of leads us to what he talks about with the future of trauma. It's wild.
Yeah, like telemedicine and all that.
A surgeon right there, guiding someone through a procedure, but they're miles away. It could change everything.
Especially, like you said, for folks who are out there, no hospital nearby.
Exactly. But I gotta say, it makes you think, what if the internet's down?
Right. Or like, who's making the calls? It's complicated.
It doesn't give you all the answers, but he makes you think. And that's what a good book does, right?
It does. So look, if you want to know what happens when things go really wrong, if you've ever been curious about those critical moments, you gotta check out Dr. Ahmed's book. Even though it's from the future, it's still relevant today.
It's a fascinating look at what it takes to be a trauma surgeon, what they face every day. It's intense for sure, but honestly, it's a page turner. All right, so today we are diving headfirst into the world of trauma care.
Yeah, we're going to try to equip you with the must-knows.
Yeah, exactly. Those essential things that medical professionals use when they're facing, those really high-pressure emergency situations.
Like that.
And we're taking all those dense medical textbooks and kind of like distilling it, exactly, to the good stuff so you can walk away feeling empowered, not overwhelmed, right?
Precisely.
Because nobody wants to be overwhelmed by medical jargon.
Yeah, it's about taking action, not panicking.
Exactly. So picture this. You're in a situation where someone needs immediate medical attention. Our source material today, Initial Assessment and Management, it's like the ultimate playbook for these scenarios.
It is, yeah.
And it kept highlighting this thing called the golden hour.
Right, which is a bit of a misnomer. It's not actually about a full 60 minutes,
Oh, really?
Yeah, it's more about that critical window right after an injury.
So, like, every second counts.
Yeah, when taking swift action has the biggest impact on whether someone pulls through.
Okay, so it's less about the clock and more about that immediate response.
Absolutely.
So what happens during this golden hour? What's the first order of business?
So medical professionals, they rely on a systematic approach. And this is where you'll often hear that acronym ABCDE.
ABCDE, okay.
Airway, breathing, circulation, disability, and exposure.
Okay, they tackle them in that order.
Yeah, because it's all about prioritizing. Those are the things that pose the most immediate threat.
Makes sense. I mean, you can't really move on to anything else if someone's not breathing.
Right, exactly, you've got it.
So let's break down the ABCDEs a bit, starting with A, airway. It seems kind of straightforward.
It does. But you'd be surprised how easily an airway can get blocked, especially if someone's unconscious.
Even a minor blockage can become a huge issue, right?
Absolutely critical.
Now, our source material mentioned these things called oropharyngeal airways.
Oh, yeah.
And I've got to ask, what are those? Because the name sounds a little intense.
They are, well, picture like a curved tube that helps keep the airway open.
Oh, okay.
Yeah, and medical professionals, they're trained to use those to make sure oxygen can get in.
That's good to know that they've got those tools ready to go.
Absolutely.
So we've tackled the airway. What about B, breathing?
Right. So with breathing, it's more than just checking for a pulse. It's really about those signs of respiratory distress, things that, even you or I might notice.
Like if someone's chest isn't moving normally.
Exactly. Or if
They're
they're
just
struggling for each breath.
Gasping for air. Yeah.
Exactly. Those are the telltale signs.
So it's like our bodies have these built-in alarms, and knowing what those alarms look like is key.
Yeah, for sure.
Okay, so what about C, circulation? And that's where checking the pulse comes in, right?
It is, but there's another test that anyone can do, really straightforward. You just press on a fingernail and you see how quickly the color returns. And that's called capillary refill time. And if it's sluggish, it could mean there's a circulation problem.
Wow, it's like a little secret medical handshake.
Uh-huh.
But now we're in the know, too.
Exactly.
So we've made it through the ABCs, but this golden hour, it doesn't stop there, right? We've still got D and E to uncover.
You got it. Moving on to D, disability. And now when we talk about disability here, we're really talking about neurological function, how the brain is working after, a potential injury.
Okay, that makes sense. So how do you assess that so quickly in those initial moments?
So they use something called the AVPU scale. It stands for alert, verbal, pain, unresponsive.
Ah.
It's a fast way to figure out someone's level of consciousness.
So if someone responds to a voice, but they're not totally aware of what's going on around them, that tells you something.
Exactly. It gives you a starting point for understanding their neurological state and helps figure out the next steps.
Kind of like a mental checklist for an emergency.
Exactly. And finally, E, exposure. Now, this one might seem a little counterintuitive. Like, why would you take clothes off in an emergency?
Yeah, wouldn't you want to keep someone warm, especially if they're hurt?
You're totally right. And preventing hypothermia, that's a crucial part of E too. But think of it this way. You can't treat what you can't see.
Right.
Exposing the patient, while obviously being really careful about their body temperature, it lets you do a full head-to-toe check. You got to find those hidden injuries.
It's like that saying, but instead of no stone unturned, it's no bandage left unturned, right?
Exactly. You need that full picture to give the best care.
So it's not just about checking boxes, this ABCDE approach. It's like a whole mindset of how to prioritize in those critical moments.
Absolutely. It's about those life-saving actions right after a trauma happens.
And once you've addressed those most urgent threats, then what? Then the focus shifts to stabilizing the patient, right? That's where we get into those hands-on procedures, those techniques we were talking about. And our source material, initial assessment and management, it really dug into hemorrhage control.
Which is key, because uncontrolled bleeding, that's a huge risk in trauma.
Of course.
Direct pressure on the wound,
Yeah.
that's often the fastest and most effective way to get that bleeding under control.
And if that's not enough, what if direct pressure isn't working?
Then you might need a tourniquet.
Ah.
Not always the go-to, but it can be absolutely life-saving when you're dealing with really severe bleeding.
It's amazing how something as, seemingly basic as just applying pressure can be so crucial.
It all boils down to controlling those things that are super critical for survival, right?
Totally. Now, our source material also mentions something called a FAST exam. What's that all about?
So FAST stands for Focused Assessment with Sonography for Trauma. Basically, it's a really quick ultrasound.
Okay.
It's used to find internal bleeding really, really fast.
So like a portable X-ray vision for doctors?
You could say that. It's a way to get essential information about what's happening inside, right there at the patient's side, without having to do anything invasive.
That's incredible how technology is playing such a huge role.
Absolutely. And another thing that's super important that our source material highlighted is cervical spine protection.
So protecting the neck and spine.
Exactly. In trauma situations, you always got to think worst case scenario, especially with potential spinal injuries.
Right, so immobilizing the spine is key.
Absolutely. That means using a neck brace, other techniques, just to make sure there's no movement that could cause more damage.
It's all about minimizing risk, minimizing a further injury.
Exactly. And another thing that's super important for stabilization, and our source material dug into this, is shock management.
Okay, now when I think shock, I think, someone's scared or surprised. But it sounds like we're talking about something way more serious here.
You're right. Medically speaking, shock, that's a life-threatening condition.
Yeah.
It's when your body's not getting enough blood flow to those vital organs.
Oh, wow.
And after a traumatic injury, there are a bunch of different reasons why that might happen.
So how do you even begin to manage shock in that kind of situation?
A lot of times it involves something called fluid resuscitation.
Okay.
You're basically making sure the circulatory system has enough fluid volume, enough, liquid in the pipes, so to speak, so that it can work properly.
So giving the patient fluids through an IV.
Yeah, exactly. But it's not just about pumping in as much fluid as possible.
There's a balance.
You've got to find that sweet spot. Too little, and the body can't recover, right?
Yeah.
Too much, and you risk causing more problems, like messing with the blood's ability to clot, which could lead to, more bleeding.
Wow, it's like you're trying to build a house of cards, but on top of a waterbed, it just wouldn't work.
Exactly. It's about being precise and calculated with those interventions.
I'm realizing just how much goes into this, all the factors they're considering, making these decisions on the fly.
It's really, really complex, and that's what makes this field so amazing.
It's not just about knowing what to do, it's knowing the why and the when.
100%. And that becomes even more important when you start talking about specific populations. Different people, different situations. Trauma care, it's not one size fits all.
Because everyone's body's different, they react to trauma in different ways.
Right. And that's actually what we're going to dig into after the break. How age, pre-existing conditions, even just the scale of an incident, it can all change how you approach trauma care. So stick with us, because it's about to get even more interesting as we take this deep dive to the next level.
And we are back, diving right back into this fascinating world of trauma care.
Where things are rarely straightforward.
Right, like we've talked about the golden hour, the ABCDEs, those essential techniques to get someone stable.
Right.
But as our trusty source material, initial assessment and management points out, it's not always clear-cut.
Definitely not. It's about adapting on the fly.
Because people are different.
Exactly. And that's especially true when we're talking about kids or older adults. Trauma care isn't one size fits all.
So even though on a basic level, our bodies react to trauma in somewhat predictable ways,
Right.
when you factor in things like age, pre-existing conditions.
It adds a whole other layer of complexity, absolutely.
Take pediatric trauma. I mean, kids aren't just small adults, are they?
No, not at all. Their bodies, they just respond so differently to injury.
Their physiology is just different.
Completely. And their emotional needs in those situations are completely different too.
Right. You can't forget about that aspect.
You can't just treat a kid the same way you treat an adult.
You need that specialized knowledge.
Exactly. The way you communicate, the specific things you do medically, it's all different.
Our source material really stressed that, right? Like treating children, it's its own thing.
Absolutely. A whole different ballgame.
And then on the other end of the spectrum, you've got geriatric trauma, treating older patients.
Right. And that comes with its own unique challenges.
Because a lot of times, older adults might have other health issues going on.
Exactly. And medications. Lots of medications to consider.
And those can really impact how you approach treatment for an injury.
Absolutely. You've got to think about potential interactions between those medications.
Right.
How age-related changes in the body might change how you make decisions.
It's like solving a medical puzzle, but with all these extra pieces thrown in.
That's a great way to put it. You've got to connect the dots.
And do it all quickly.
Exactly. And that's what makes it so demanding, but also so rewarding.
Absolutely. And then there are those situations, I mean, we've been talking about individual patients so far.
Right.
But then you have these mass casualty incidents.
Where everything gets amplified.
Exactly. Where it's not just one person, but dozens, maybe even hundreds, all at once.
It's a whole different ball game.
How do medical teams even start to wrap their heads around that?
Well, our source material talked about something called START.
START. Okay.
It stands for Simple Triage and Rapid Treatment. And it's designed for those overwhelming situations where you have to make quick decisions about who needs immediate care.
So like a rapid fire assessment.
Exactly. You assess, you prioritize, because resources are often limited.
And time is of the essence.
Exactly. It's all about making those incredibly tough calls quickly and efficiently.
To save as many lives as possible.
Precisely. That's the ultimate goal.
Wow, we've covered so much ground in this deep dive, from those crucial steps for a single patient
Right, those core principles.
to the immense challenges of these mass casualty situations.
It's a whole spectrum.
It really highlights just how skilled, how much expertise these medical professionals have.
Absolutely. They're the ones running towards the chaos while everyone else is trying to escape it.
So well said. As we wrap up, what are we hoping our listeners take away from all of this?
Yeah, what's the takeaway?
We don't expect anyone to become a trauma surgeon after listening to us.
Right, of course not. But
But even this basic understanding, this awareness,
it can be incredibly empowering.
it can, because it makes us feel a little less helpless, right?
Absolutely. Knowing those first steps, what to look for, it could make all the difference.
Exactly. And maybe it even inspires someone to take a first aid course or something.
That would be fantastic. Knowledge is power.
Because at its core, this is about people helping people.
Absolutely, that human connection in the most vulnerable moments.
Well, to all our listeners out there, thank you for joining us on this deep dive. Stay curious, stay informed, and until next time, remember, knowledge is power. Okay, so ready to dive into this mountain of info you gave me on airway and ventilatory management?
Absolutely. It's a lot to unpack, but I think you got some really good stuff in here.
Well, I tried to be thorough, you know me. But seriously,
Yeah.
It's critical stuff, right? We're talking about those moments when someone's life is literally on the line.
You got it.
Yeah.
And in those situations, knowing your stuff can make all the difference. That's why I like to bring it back to the basics, those ABCs you learn early on.
Right. Airway, breathing, circulation. So are you saying even before we think about bandages or medications or anything else, it's all about the airway?
100%. Because if you don't have a patent airway, nothing else matters. You're not getting oxygen to the brain and the body, and every second counts.
You're really emphasizing that every second counts. You know, in your notes, you even mentioned that case.
You mean that hiker? The one who had fallen and was struggling to breathe.
Yeah, exactly. What was the issue there?
It turned out to be a partially obstructed airway. Some swelling was involved, but let me tell you, those first few minutes felt like an eternity.
And that's with you knowing what to do. So for those of us who might panic in that situation, walk us through it. Say we're first on the scene, someone's injured. How do we even assess the airway? What are we looking for?
You got to use your senses. You're listening for any unusual sounds and looking for any signs of struggle.
Okay, so what kind of sounds are we talking about here? Give me the soundtrack of a compromised airway.
Think of it like a symphony, but instead of beautiful music, you're listening for sounds of distress.
Okay, so not the kind of symphony you want to be hearing.
Definitely not. You might hear stridor, that high-pitched wheezing sound.
Yeah, I've heard that before. It's pretty distinct.
Exactly. That's a big red flag. Or you might hear hoarseness in their voice or gurgling sounds. None of those are what you want to hear.
So those sounds, trouble. Got it. And visually, anything stand out?
Yeah, you might see them struggling to breathe, really using their chest muscles, or their lips might be turning blue, a sign called cyanosis.
Okay, so we've identified a potential airway obstruction. What's our next move? What tools do we have to open things up?
So you've actually got it right in your notes. Jaw thrust maneuver is usually our go-to, especially if there's any suspicion of a neck injury.
Right, protect the spine, got it. But how effective is the jaw thrust, really? It can be surprisingly effective. You're basically just moving the jaw forward to pull the tongue away from the back of the throat, creating that vital space for air to flow. And that's often all it takes.
Sometimes, yeah. But of course, we've got other tools too, OPAs and MPAs, oropharyngeal and nasopharyngeal airways.
Okay, those are in my notes too, but remind me again when we'd use those. So we've got those initial maneuvers down, but what about those situations where even a clear airway isn't enough? I'm looking at my notes here and things are getting serious. We're talking intubation.
Right. Sometimes we need to take over the job of breathing for the patient.
Exactly. And it looks like you can't really talk about airway management without talking about intubation.
Absolutely. It's the gold standard for securing an airway in those really critical situations.
And I noticed in my notes here, you really get into the nitty-gritty of intubation. I mean, you didn't hold back.
Well, it's such an important procedure, and you want to be prepared for anything, right?
For sure. But let's back it up a bit for those who might not be as familiar with the ins and outs. When would we make that call to intubate? What are the signs that it's time to take that step?
Okay, good question. Think of it like a spectrum. On one end, you've got someone who's having a bit of trouble breathing, but they can still cough, they can still protect their own airway.
Okay, so they're still conscious, still somewhat in control.
Right, but on the other end of that spectrum, you've got respiratory failure, maybe a severe head injury, situations where the body is just overwhelmed and can't maintain oxygen levels on its own.
So that's when we got to intervene, take over for the body's own systems.
Exactly, and that's where intubation comes in.
Got it. Now, you mentioned RSI earlier, rapid sequence intubation, and my notes are a bit cryptic on that one. What's the deal with RSI? When does that come into play?
You're right to flag that. RSI, that's a whole other ball game. Imagine this, you've got a patient who's unconscious, airways compromised, and there's a high risk of aspiration.
And just to clarify for our listeners, aspiration means?
Good point. Aspiration means that stomach contents could end up in the lungs, which you can imagine is a recipe for disaster. So RSI is a meticulously choreographed sequence of medications and maneuvers, all designed to secure the airway as quickly and safely as possible, minimizing that risk of aspiration.
Okay, so we're talking high-stakes choreography here.
You could say that.
So let's say we've successfully intubated the patient. How do we know for sure that that tube is right where it needs to be?
That's the million-dollar question, right? We use a few things. First, we're watching for that chest rise and fall with each breath. We're also listening carefully for breath sounds on both sides of the chest, making sure air is getting in both lungs.
So those are our sort of immediate visual and auditory cues.
Exactly, but we've also got technology on our side too. Capnography, for instance, measures the CO2 in the exhaled breath.
So it's like a real-time gauge of whether the patient is actually exchanging air effectively.
Precisely. It's amazing how technology can give us that immediate feedback.
For sure, it's an extra layer of reassurance. But what about those situations where, and my notes mention this too, what about those situations where intubation isn't straightforward, where you encounter a difficult airway?
You're really on top of this. You know that not all airways are created equal.
Well, that's what I'm here for. But seriously, what do we do when we encounter those tricky situations?
Well, that's where those difficult airway algorithms you've got in your notes come in.
Okay, so those are like our roadmaps for navigating those choppy waters.
Exactly. Think of them as our backup plans.
So plan A, plan B, maybe even a plan C up our sleeves. What are some of the specific tools or techniques we can turn to when things get complicated? So it sounds like we've got a whole arsenal of tools and techniques to handle those difficult airways.
We do. And that's a good feeling, knowing you've got options.
Absolutely. But I imagine even when we successfully navigate all that, intubate the patient, we're not completely out of the woods yet, are we?
You're right. Securing the airway is a huge win, but it's just the beginning.
So what happens after the initial crisis is over?
Well, then it becomes all about long-term management.
And that's where all this other stuff in my notes comes in, I'm guessing. All those details about ventilator settings, monitoring for complications.
Exactly. We've got to make sure that artificial airway is doing its job, but not causing any harm in the process.
Right, because it's not like breathing through a straw. There's a lot more to it.
Way more to it.
Yeah.
We're talking about fine-tuning those ventilator settings to match the patient's individual needs, making sure they're getting enough support, but also avoiding any damage to their lungs.
That's a delicate balance.
Very delicate. And then on top of that, you've got to be constantly vigilant, monitoring for things like infection, because that tube going into the lungs can be an open door for bacteria, and we don't want any uninvited guests setting up shop.
Definitely not. That sounds like a recipe for disaster. And then my notes mention something about pulmonary embolism too.
Ah, yes, that's another risk to keep in mind. Pulmonary embolism, that's a blood clot that travels to the lungs, and it can be a life-threatening complication.
So you really do need eyes everywhere, a sixth sense for potential problems.
You got to be proactive, anticipating what could go wrong and being ready to act fast.
It's a lot to juggle. And speaking of juggling, you mentioned earlier that different patient populations can present unique challenges.
Absolutely. One size does not fit all in airway management.
And I noticed you called out pediatric patients and those with obesity in my notes. So what makes those cases different?
Well, with kids, their anatomy is just different. Their airways are much smaller, more delicate, so you need specialized equipment and a very gentle touch.
Makes sense. You can't treat a child like a small adult.
Exactly. And then with patients with obesity, positioning can be really key.
Like that ramped position I saw in my notes.
Exactly. It's all about optimizing the airway, making sure we can ventilate effectively.
Wow, this has been quite a journey. We've covered so much ground today, from those first few seconds at a scene to all the complexities of long-term care. If you had to pick one takeaway, the most important thing for our listeners to remember, what would it be?
I'd say never stop learning. Your meticulous notes and thoughtful questions tell me you've got that covered, but it goes for everyone out there listening. Your knowledge and skills can literally save a life. Never underestimate the impact you can have.
So powerful and so true. Big thanks to you, as always, for sharing your expertise and for reminding us that in airway and ventilatory management, the learning never stops. And to our listeners, keep those brain cells buzzing, keep asking those tough questions, and we'll see you next time for another deep dive. Hey, listener. Ready for another deep dive?
Absolutely.
Today, we're tackling something I think we all worry about: head injuries.
Yeah, it's one of those things, right?
Better safe than sorry, as they say. But what's actually going on in our brains when they get, well, bumped?
It's a question that's puzzled doctors for centuries. And the more we learn, the more we realize that even little bumps can have a big impact.
Okay, so let's say you're at the scene of an accident and someone's down. Maybe they hit their head.
First things first, you got to act fast, but stay calm, right?
Right.
Those first few minutes.
Yeah.
They're crucial. We call this the primary survey. Basically, you're checking for anything life-threatening: airway, breathing, and circulation. You're buying time until the professionals get there.
So the ABCs. Got it. Making sure they're breathing, no major bleeding. But what about the stuff we can't see? Those hidden signs of a head injury.
That's where the Glasgow Coma Scale comes in.
Yeah.
GCS for short. Now, I know it sounds complicated, but
A little bit, yeah.
it's actually pretty straightforward.
Okay.
Even without any medical training, you can use it to assess someone's consciousness.
How so?
You're basically checking three things. Can they open their eyes? What's their verbal response like? And how are they moving?
Makes sense.
A low score on this scale. Big red flag. Even a single point drop on the GCS can mean a way higher risk of long-term problems.
Wow, I had no idea it was that sensitive. So low score equals bad news. Anything else we should be looking at?
The pupils.
Their eyes.
Yep. They should be the same size and react to light. If one's bigger than the other or not reacting right, that could be increased intracranial pressure.
Okay, hold on. Intracranial pressure, that sounds serious.
It is. Think of your brain like a balloon
Okay.
and your skull's like a helmet. Now imagine blowing more and more air into that balloon. What happens?
It's going to put pressure on the helmet.
Exactly. That's intracranial pressure, or ICP. Too much pressure, and it starts squeezing the brain.
That can't be good.
Not at all. It can cause some serious damage.
So what happens if someone has crazy high ICP? How can you tell?
There's something called Cushing's triad. High blood pressure, a heart rate that's slowing down, and their breathing gets all irregular.
That's a lot going wrong at once.
It's basically a distress signal from the brain.
Yeah.
And if it goes on too long, there's a risk of herniation.
Wait, herniation? Like a slipped disc in your back?
It's not exactly the same, but kinda.
Yeah.
Imagine the brain being pushed so hard against the skull it starts to push through any opening it can find.
Okay, yeah, that's definitely not good. Makes you realize how fragile the brain really is. But you mentioned other types of brain injuries, not just this pressure buildup.
Absolutely, and those are important to understand too.
So we've been talking about ICP, all that pressure inside the skull,
Right.
but you mentioned there are other ways the brain can be injured, even without that extreme pressure.
Exactly. We've got to remember the brain itself can be directly injured. One of the most common we see is a subdural hematoma.
Hematoma, that's a blood clot, right?
You got it. A subdural hematoma is a blood clot that forms between the brain and the skull. And here's the thing, they can happen slowly, even after a seemingly mild injury.
See, this is what gets me. I think a lot of people assume if you don't get knocked unconscious, you're probably fine.
Right, and that's not always true.
But what you're describing is you could feel okay initially and then...
Things can take a turn, definitely.
Wow.
That's why we always talk about those delayed symptoms. Just because someone seems fine right after a bump doesn't mean we can let our guard down. Another type of hematoma we see is an epidural hematoma. It's a little different.
How so?
Well, this type of blood clot forms between the skull and the dura mater,
The duramater.
the outer layer of the brain. And epidural hematomas, these can develop really fast.
So with a subdural hematoma, it might be a slow bleed. But epidural, we're talking.
Yeah, much faster.
Yeah.
Someone with an epidural hematoma might lose consciousness, wake up for a bit, and then deteriorate really quickly.
Oh, wow. So much faster and that much more dangerous.
It's a true emergency.
Okay, so different types of bleeds, different speeds, different levels of danger. But you also mentioned other types of brain injuries, not just these hematomas, right?
You bet. There's another one called diffuse axonal injury, or DAI for short. And it's different from the hematomas we've been talking about.
Okay. In what way?
Well, it's not so much about the bleeding, but more about damage to the actual nerve fibers in the brain, like shearing or tearing of the axon.
Shearing, like if you twist your ankle really badly.
Yeah, kind of like that, but happening inside the brain.
Ouch.
And unfortunately, DAI is really common in those high-impact situations like car accidents or really bad falls.
Makes sense. All that force being transferred to the brain.
And to make matters worse, DAI is often more severe in folks who are on blood thinners because they're more likely to bleed inside the brain.
Right, so more bleeding on top of the shearing.
Exactly.
Okay, so let's say someone suspects a head injury, maybe after a fall or something. What happens next? How do doctors even begin to figure out what's going on inside the brain? So we've talked about all these different types of injuries: subdural hematoma, epidural hematoma, diffuse axonal injury. It's a lot. And honestly, kind of scary.
You're right. Head injuries are nothing to mess with. But the good news is we've got ways to figure out what's going on.
So let's say someone's worried, maybe they hit their head or something. What happens next? What do doctors actually do?
Well, one of the most important tools we have is a CT scan.
A CT scan, that's like taking an x-ray of your brain, right?
Exactly. But CT scans give us way more detail.
So you could actually see what's happening inside the skull.
You got it. We can see bleeding, swelling, even if there's a fracture in the bone. It's really remarkable.
So once you've got that picture from the CT scan, then what? How do you actually treat a brain injury?
It really depends on what we're dealing with. Each injury, each person, it's all a bit different. But the big picture goal,
Yeah.
to protect the brain from any further damage, that often means controlling that intracranial pressure we talked about, making sure the pressure doesn't get too high.
Right, like reducing the swelling and stuff.
Exactly. And we also want to manage pain, make sure the patient is as comfortable as possible, and do everything we can to prevent seizures.
Seizures, right,
Yeah.
because those can cause more damage, I imagine.
Absolutely. Now, for some injuries, especially if they're more severe,
Like a really big bleed.
yeah, in those cases, we might need to go in surgically.
Brain surgery.
It sounds scarier than it is, but
Still scary, though.
for sure. But sometimes it's the best option, to relieve pressure, remove a blood clot, things like that.
So much of this feels like, okay, something's really wrong. We need to fix it now. But what about the long term?
You're hitting on a really important point. Brain injuries, they're not just about the initial trauma.
Right. What about the weeks and months after?
That's when we often see post-concussion syndrome. It can impact people in so many ways.
Post-concussion syndrome, is that like you've just got a headache that won't quit?
It can be headaches, definitely, but it can also be dizziness, fatigue, just this overwhelming sense of being drained. Some folks have trouble with their memory, can't concentrate the way they used to.
So their thinking is foggy.
Exactly. And for some, even their senses are affected. Sounds might seem louder, lights might feel too bright. It can be really debilitating.
And this can last for
Weeks, months, even years in some cases.
It's amazing to me how even what seems like a minor head injury can have these long-lasting, invisible consequences.
That's why awareness is so important.
So what can people do if someone's facing a long road to recovery? What helps?
Rehabilitation is key. And it's not one size fits all. We're talking physical therapy, speech therapy, even cognitive therapy to help with thinking and memory.
So it's really about retraining the brain.
In a way, yeah. And I think the most important thing is for people to be patient with themselves. Healing takes time.
It always does, doesn't it?
It really does. And when it comes to the brain, well, let's just say it's worth taking the time to heal properly.
Couldn't agree more. This has been a real eye-opener.
I agree.
To think even just bumping your head can have such a big impact.
It really can. So folks, be careful out there.
Seriously, protect your brains, listen to your body. And if you're ever unsure, it's always better to err on the side of caution and get checked out.
That's great advice.
Until next time, everyone. Ever walked past those ER doors and just felt that wave of intensity, like something big is happening? Well, today, we're like flies on the wall, getting a backstage pass to thoracic trauma, those critical injuries to the chest. And we're going deep into Chapter 4, Thoracic Trauma Revision Notes, not to replace those textbooks, but to give you the highlights you're going to remember.
What's fascinating about thoracic trauma is that speed is everything. When we talk about these injuries, we have a very systematic approach because some of them can be fatal within minutes.
Okay, so paint a picture for me. A patient arrives with chest trauma. What's the first thing that pops into your head?
The first thing we think about is tension pneumothorax.
And
That's where the lung is being squeezed, like a balloon. The pressure builds with every breath they take. We call it the kill zone for a reason.
Okay, so what are some of those signs and symptoms, those red flags that tell you this is a tension pneumothorax?
So imagine the lung is being squeezed like a balloon. It's all about pressure, right? So you're going to see their veins in their neck bulging. They might be struggling to breathe. And one side of their chest might sound oddly quiet when you listen with your stethoscope.
Oh, wow. Okay, so every second counts in that situation.
Absolutely. You need to relieve that pressure, fast needle decompression, then get that chest tube in.
Intense. The source material also talks about open pneumothorax, also called a sucking chest wound. What's the key difference there?
With an open pneumothorax, think of it as a breach in the chest wall. Air is being sucked directly into the chest cavity, disrupting the normal breathing process.
So the lung can't create the right pressure to function.
Exactly.
How do you manage that?
So we need to seal that breach. And we do that with a special dressing, an occlusive dressing, taped on 3 sides. It allows air to escape, but not enter.
Clever. Now, shifting gears from air to blood, what about a massive hemothorax? What is that?
Essentially, it's a significant amount of blood filling the chest cavity, which compresses the lung and prevents it from expanding. So internal bleeding, but within the chest.
So would the symptoms be related to both blood loss and difficulty breathing?
Exactly. You'll see signs of shock, pale skin, rapid heart rate, confusion, low blood pressure, and when you listen to their chest, it might sound dull on the affected side.
Another situation where every minute counts. So what's the game plan there?
Same principle, relieve the pressure. We insert a chest tube to drain the blood and allow that lung to re-expand.
Got it. Okay, what about flail chest? That sounds incredibly painful.
It is. It's essentially when a section of the rib cage breaks in multiple places, becoming detached from the chest wall, which disrupts the normal mechanics of breathing.
And our source material mentions paradoxical chest wall movement.
Right.
What does that look like?
It means that the injured part of the chest wall moves inwards during inhalation and outward during exhalation, opposite of what it should be doing.
Wow.
Breathing becomes incredibly inefficient and often very painful, and usually signals an underlying pulmonary contusion.
Which is?
It's like a bruise, but on the lung. It can severely impair the lung's ability to do its job to exchange oxygen and carbon dioxide.
So with a flail chest, you're dealing with both a mechanical breathing problem and a lung injury. How do you approach that?
We focus on pain management to help them breathe better, provide oxygen therapy, and sometimes even use mechanical ventilation if needed.
It sounds complex. Okay, last but not least, we have cardiac tamponade.
This one is less common, but just as deadly if we miss it. Imagine the heart is encased in a sac, the pericardium. In cardiac tamponade, this sac fills up with blood or fluid, squeezing the heart.
So cardiac tamponade is like a pressure crisis, but this time it's the heart that's being squeezed. What are those red flags?
Think of it as the heart struggling to function under pressure. You'll see low blood pressure, distended neck veins, those telltale signs of pressure, and muffled heart sounds because the fluid is essentially muffling the heartbeat.
Wow. So similar to those other conditions, the goal is to relieve that pressure.
Exactly. We perform a procedure called pericardiocentesis, using a needle to drain the fluid from that sac surrounding the heart. Again, time is of the essence.
We've covered a lot of ground already. Feels like we've just run a marathon through the ER, but we're not done yet, right? Thoracic trauma, there is more to it than just those initial heart-pounding moments.
You're absolutely right. Stabilizing those immediate threats is just the first step. We then shift into detective mode to uncover the full extent of the injuries.
Like piecing together a puzzle, I imagine. Our guide, Thoracic Trauma, revision notes, highlights imaging and additional tests as those crucial next steps.
Precisely. We start with the trusty chest x-ray, our workhorse. It's quick and gives us a good overview, like seeing the crime scene for the first time. We can often spot pneumothorax, hemothorax, rib fractures, those key players.
But sometimes you need a more powerful magnifying glass. What other tools come into play?
If we suspect something's going on that we're not seeing, we turn to the fast exam focused assessment with sonography for trauma. It's a rapid ultrasound that can quickly detect fluid around the heart or lungs.
So FST helps us see those more subtle fluid collections. And our source material also mentions CT angiography. That's all about getting a detailed look at the blood vessels, right?
Exactly. Let's say we're concerned about damage to the aorta, a common concern in a high-impact trauma. CT angiography gives us a 3D roadmap of those vessels, pinpointing any injuries with incredible precision.
Because even a small tear in the aorta could have devastating consequences later on.
You got it. It's all about connecting the dots, understanding the mechanism of injury, and using the right tools to confirm our suspicions.
So far, we focused on the more common injuries. But our notes also highlight some less frequent but still significant injuries. One that caught my eye was diaphragmatic injury. The diaphragm almost sounds too delicate to withstand trauma.
You'd be surprised. It takes more force than you might think. But blunt trauma from a car accident or a fall can definitely injure it. And sometimes even forceful coughing or vomiting, especially in someone with a pre-existing weakness, can cause a tear.
It's amazing how much force can be transferred within the body. Another injury that seems unexpected is esophageal rupture. What usually causes that?
This is usually associated with severe vomiting. Imagine someone who's been vomiting forcefully. That pressure can actually rupture the esophagus, the tube connecting the mouth to the stomach.
You don't often think about the force behind those everyday actions. And the last one on the list here, traumatic asphyxia.
It is. Imagine someone being crushed or pinned under a heavy object. That immense pressure on the chest restricts blood flow back to the heart. And you see this distinctive pattern of bruising on the face, neck, and chest as the blood is forced upwards.
So traumatic asphyxia isn't just about breathing, but the immense pressure impacting the circulatory system.
Precisely. And because it's caused by such extreme force, we always look for other associated injuries, cardiac problems, spinal injuries, head injuries. It's rarely an isolated injury.
Thinking about all of this makes me realize how easy it would be to miss subtle signs if you aren't incredibly thorough.
That's why a methodical approach is crucial for every single patient with thoracic trauma. We can't afford to miss a thing.
We're back with our thoracic trauma deep dive. We've navigated that kill zone, talked about those crucial assessments, but they say the devil's in the details, right? So what are some of those don't forget elements that can really make a difference in patient care.
It's easy to get caught up in the algorithms and protocols, but remembering that each patient is unique is crucial. What seems minor in one person could be a red alert in another.
So we're talking about individual factors here. What's a good example of that?
Let's take rib fractures. A single rib fracture in a healthy young adult, likely to heal well. Painful, yes, but not usually life-threatening.
But you're saying that changes with older adults.
Absolutely. With older adults, rib fractures, even from minimal trauma, can be much more serious. Their bones are more fragile, they might have other health conditions, and their risk of complications, like pneumonia, goes way up.
Makes sense, because if it hurts to take a deep breath, you're not clearing your lungs effectively.
Exactly. So, our approach has to be tailored to the individual. Age, health history, other vulnerabilities, it all factors in.
The art of medicine, right along with the science. What other seemingly small details can have a big impact?
Don't underestimate those basics like high-flow oxygen. It's a cornerstone of thoracic trauma management for a reason.
Back to basics. So why is oxygen so essential in these cases?
Think about it. What's the common denominator in most thoracic trauma? Compromised breathing, right? Collapsed lung, blood in the chest, bruised lung tissue. It all adds up to less oxygen getting where it needs to go. Supplemental oxygen helps us ensure adequate delivery and prevent further complications.
Got it. So even if someone's not visibly struggling for air, high-flow oxygen is still the standard.
Absolutely. It can significantly impact recovery, even if you don't see the effects right away.
Now, we've been talking about thoracic trauma in general, but our notes also highlight some specific considerations for different populations. Children, for example.
Kids, they're interesting because their bodies respond to trauma differently. They're actually more prone to lung injuries because their chest walls are more flexible. They might not break ribs as easily, but that force of impact can still be transmitted to those little lungs.
Interesting. And then on the other end of the spectrum, we have the elderly population. What makes their care unique?
With elderly patients, it's all about anticipating those potential problems. They're more likely to have pre-existing conditions, their bones are more fragile, and their physiological reserves, well, let's just say they're not what they used to be. We had to be incredibly diligent, especially with pain management.
Because you don't want to mask any underlying complications.
Exactly. Careful observation, individualized care plans, and a healthy dose of anticipating potential issues. Those are key.
This deep dive has been amazing. We've covered so much ground, from those initial life-saving interventions to those subtle but crucial details that can make all the difference.
And the learning never stops. Thoracic trauma is a complex puzzle. Every piece is connected.
It's a challenging field, but incredibly rewarding, I'm sure. That's all the time we have for today. But listeners, here's something to think about. We've talked about recognizing the signs and symptoms of these injuries, but what if those symptoms are masked, hidden beneath other factors? It's something to ponder. Thanks for joining us for this deep dive. We'll see you next time. Okay, so picture this. You're watching an action movie.
Okay.
And the hero's car gets T-boned by like a runaway 18-wheeler. Sends the hero flying through the air.
Yeah.
You know, metals crunching, glasses shattering. It's total chaos, right?
Yeah.
Well, today's deep dive is all about what happens inside the body during those kinds of intense impacts.
Yeah.
We're talking abdominal and pelvic trauma.
Right.
And let me tell you, it's some serious stuff. We're going deep into a medical text that cuts right through the fluff, you know, gives you that need-to-know information on how to handle these ticking time bomb situations.
I like it.
Think of it like this. We're giving you a backstage pass to the world of trauma care.
Gotcha.
It's all about high stakes, making those split-second decisions, and having a whole lot of expertise to back it all up.
For sure.
So first things first, we've got to talk about the difference between blunt trauma and penetrating trauma. It's kind of like the difference between, say, getting hit by a baseball bat versus getting stabbed with a knife. Right.
Exactly. Yeah.
One's a blunt force, the other's sharp and focused.
Yeah, and, you know, it might seem obvious that, like, a stabbing is incredibly serious. Yeah. But honestly, blunt trauma can be just as dangerous.
Really?
Oh, yeah. In fact, sometimes even more so.
Wow, why is that?
That-
You'd think a knife wound.
Well, because with blunt force,
Yeah.
you have this massive impact.
Right.
And it sends these shock waves through your entire body.
Oh, wow.
And it can cause this
Oh, I see.
widespread internal damage,
Okay.
even without breaking the skin.
So you're saying, like,
Imagine your organs are just getting jostled around inside.
ouch. Yeah.
Not good.
No, not good at all.
And that's why that initial assessment, when a patient comes in,
Yeah.
it is absolutely critical.
Yeah, it's like being a detective at a crime scene.
Exactly.
But the clues are hidden inside the body, right?
Exactly.
So how do you even begin to...
Well, that's where the FAST exam comes in.
The FS exam, what's that stand for?
It stands for Focused Assessment with Sonography for Trauma.
Sonography. So we're talking like an ultrasound.
You got it.
Okay.
It's basically a quick and painless way to check for internal bleeding.
Using sound waves.
Using sound waves, yep.
Wow. So it's like having x-ray vision,
Kind of, yeah.
but with sound.
Yeah, it's pretty amazing technology.
That is pretty cool.
But, for really
Yeah.
detailed imaging, we often turn to CT scans.
DT scans.
Those give us a 3D roadmap of the injuries, show us exactly what's going on inside.
That makes sense.
Whether an organ is damaged, if there's active bleeding, the works.
Okay, but what about radiation exposure? I always hear about that with CT scans.
Yeah.
Is that a concern in these situations?
It's a valid concern,
Yeah.
for sure.
Yeah.
But in these life or death situations,
Right.
the benefits far outweigh the risks.
Right.
The information we get from a CT scan
Yeah.
could be the deciding factor
Wow.
in whether or not someone needs emergency surgery.
So you're saying with these high-tech imaging tools,
Exactly.
doctors can actually pinpoint the injured organ.
Exactly. We can see precisely what's going on.
And are some organs more,
And some organs are definitely more vulnerable than others.
like...
The liver and spleen, for example,
Okay.
those are the most commonly injured organs.
Really?
Yep, in abdominal trauma.
Is it because they're particularly...
It's all about location.
Location, okay.
They sit right behind those lower ribs.
Oh,
So they're
right.
kind of in the line of fire.
So they just take the brunt of the impact?
Exactly.
And if they are injured, then what happens?
Well, with the spleen specifically,
Yeah.
doctors, whenever possible, we try to preserve it.
Preserve it. Okay.
Why is that? Especially in younger patients.
What's so special about the spleen?
Think of your spleen as like a bodyguard
Okay.
for your immune system.
Okay.
It filters your blood, helps fight off certain types of infections.
All right.
And removing it, while sometimes it is necessary,
Yeah.
it significantly increases your risk of serious infections later on.
Wow. So something as seemingly small as the spleen
Oh, yeah.
can have a huge impact on long-term health.
Huge impact.
Wow. That makes those preservation efforts seem even more important.
It's really important.
Wow.
But sometimes the damage is too severe and removal is unavoidable.
Right.
But if we can repair it
Right.
and keep it functional,
Yeah.
we absolutely will.
That makes sense.
Gotta try.
It's like you always want to try to save a vital part
Yeah.
rather than just opting for a complete replacement.
Exactly.
Okay, so someone comes in after an accident.
Mm-hmm.
How do doctors even know
Right.
if there's something wrong internally?
That's a great question.
It's not like your stomach can yell, "Hey, I'm hurt down here."
Well,
Can it?
You'd be surprised.
Mhm.
Yeah, our bodies have this fascinating way
Okay.
of signaling distress, right?
Right.
And one of the ways is through something called peritoneal signs.
Peritoneal signs. Okay, break that down for me. What are we even talking about?
So imagine your abdomen is like
Okay.
a vault,
Right. Okay, a vault. Got it.
like a really well-protected vault.
Right.
And when something ruptures inside,
Uh-oh.
it's like setting off the alarm.
An alarm. So you're saying those peritoneal signs?
They're like
Yeah.
the body's way of saying, hey, something's wrong in here.
Got
Have
it.
to-
Pay attention.
So what kind of signs are we talking about here?
So think about someone who just got punched in the gut, right?
Oh, yeah.
That instinct to tense up
Mhm.
to guard their abdomen,
Right.
that's a peritoneal sign.
Okay.
Or if their stomach is super stiff,
Okay.
like board-like,
Yeah,
when you
yeah.
touch it,
Yeah.
that's another red flag.
Right.
These are the body's ways of saying, hey, back off. Something's not right here.
So it's like the body's natural defense mechanism,
Exactly.
just trying to protect itself from further injury.
Exactly. But here's the thing.
Yeah.
Some injuries are sneaky,
Okay.
like that retroperitoneal hemorrhage we talked about earlier.
Right, right. Yeah.
Remember that? The hidden compartment behind the abdomen
Yeah.
with the kidneys and all the major blood vessels.
All those important structures.
Yeah, you said it was like having a leak in a pipe
Exactly.
deep inside your wall.
Hard to find.
Right. And you don't even know it's happening.
And because it's tucked away back there,
Yeah.
bleeding in this area can be
Oh, so it's harder to detect?
much harder to detect, especially if those peritoneal signs aren't as obvious.
Right.
It's a dangerous combination.
That's really scary.
Yeah.
So how do doctors even catch these hidden injuries?
It takes a team,
Yeah.
real teamwork.
Okay.
We're talking trauma surgeons,
Right.
orthopedic surgeons, radiologists,
Wow. So it's everybody working together.
everybody working together.
Whoa, it's like a
To piece together the puzzle, figure out what's going on.
high-stakes game of medical detective work.
Exactly.
Speaking of teamwork, our text mentions something called damage control surgery.
Ah, yes.
What exactly does that entail?
So imagine a mechanic
Okay.
trying to fix a car
Yeah.
that's still in motion.
Oh, wow.
That's kind of what damage control surgery is like.
Oh,
It's about prioritizing those life-saving measures
right.
when time is of the essence.
Instead of a complete, overhaul, you're just trying to
Exactly.
stabilize the scene.
Stabilize, exactly.
Okay.
We control the bleeding, we prevent contamination,
Right.
we stabilize vital organs,
Okay.
and we do all of this
Yeah.
with the goal of getting that patient strong enough
To where they can handle.
for more extensive repairs
Yeah.
later on.
So it's like hitting the pause button
Exactly.
on the more extensive surgery,
Exactly.
addressing the most critical issues first.
Yep. Buying time,
Yeah.
giving them the best possible chance of survival.
Okay. That makes sense.
And speaking of stabilizing,
Yeah.
our text also mentions pelvic binders.
Pelvic binders. Those still sound a bit medieval to me.
They might sound archaic, but
Swingle.
they're incredibly effective.
Oh, really?
Oh yeah, remember how we talked about
Okay.
pelvic fractures
Yeah.
and the risk of massive bleeding?
Oh, yeah. Yeah, that was scary.
Yeah.
So you're saying these pelvic binders?
So pelvic binder
Okay.
is basically a wide band
Okay.
that's tightly fastened around the pelvis
Gotcha.
to stabilize the bones and reduce pelvic volume.
So it's not just about, like, keeping things in place.
It's about putting pressure on that area to help control the bleeding.
So it's like a high-tech pressure wrap.
Exactly.
Okay.
That can be a real lifesaver,
Especially in those first few minutes after an injury.
especially in those crucial moments
Ah.
after an injury.
And all of this is happening, like, in the ER, right?
Often. Yeah.
I can't even imagine.
Fast-paced environment.
Yeah, how quickly those medical professionals have to think
Absolutely.
and act.
It's all about quick thinking and quick action.
Wow. And things can get even more complex
Okay.
when we're talking about elderly patients
Absolutely, because
or pregnant women.
now you're dealing with additional factors.
Right, that could impact treatment decisions.
Exactly.
Like with elderly patients.
With elderly patients.
Yeah.
Sometimes those signs of internal injury
Right.
might be less obvious.
Oh, wow. Okay.
Or they might have other health conditions
Yeah.
that complicate things.
And with pregnancy,
And then when it comes to pregnancy,
you're essentially treating two patients at once.
exactly, you have to consider
Oh, goodness.
both the mother and the fetus,
So it's like a
weighing the risks and benefits very carefully.
delicate balancing act.
Absolutely.
Wow. To make sure that both patients are receiving.
The best possible care.
Yeah, that's incredible.
Every case is unique,
Right.
and these situations highlight the importance of having a really skilled,
Okay.
adaptable medical team.
A team that can think on their feet.
Absolutely.
Wow. It's truly remarkable what medical professionals can accomplish
It really is.
in these high-pressure situations.
Amazing what they do.
It makes you realize that knowing what to look for,
Oh, absolutely.
even as a bystander, can really make a difference.
Huge difference.
It really makes you realize that those car crash scenes in movies, they're not so far-fetched after all.
No, they're very real.
Even seemingly minor accidents can
Absolutely.
have some pretty big consequences.
Absolutely. Even what seems like a fender bender
Wow. Which is why
could turn out to be much more serious.
that rapid assessment is so crucial.
Absolutely. Early detection,
Yeah.
early intervention,
Yeah.
key to improving outcomes.
Totally. It's like that saying,
Yeah.
time is of the essence.
Couldn't agree more. And it's not just about
Yeah.
getting them to the hospital quickly, which is obviously important,
Right.
but it's also about
yeah.
knowing what to look for,
Oh.
knowing what questions to ask
Yeah.
so that you can be a good advocate
Advocate for the patient.
for yourself or for someone else, yeah, to ensure they're getting the best possible care.
So you're saying, like, even as bystanders,
Oh, yeah.
we have a role to play here.
Oh, absolutely.
What kind of things should we be looking out for?
So let's say you witness a car accident, right?
Huh?
And someone's complaining of abdominal pain,
Okay.
knowing the signs we talked about,
Okay.
like guarding the abdomen,
Mhm.
rigidity,
Yeah.
those peritoneal signs,
Right.
that could help you paint a clearer picture for the paramedics.
Right, right. So we
For
become
more information.
part of that life-saving chain of events.
Exactly.
Even before they reach the hospital.
Exactly. You become a vital link in that chain.
Wow. So it's like
From the moment of the injury
Yeah.
to the time they get to the hospital.
knowing the secret language of the body
Yeah,
can help you be a better advocate for yourself or for someone else.
exactly. Knowledge is power.
It's like having a secret weapon, right?
Absolutely.
That can help you act quickly
Yes.
and confidently in an emergency situation.
Exactly. And remember,
Yeah.
medical knowledge is always evolving.
Right.
So
Yeah.
stay curious.
Stay curious.
Keep learning.
Okay.
Never hesitate to ask questions.
Well said. Well said.
Never hurts to ask.
So we've taken this deep dive
Yeah.
into the world of
Abdominal and pelvic trauma?
abdominal and pelvic trauma.
It's not always pretty.
No, it's not, but it's something that we don't think about
Nope.
until we have to.
Exactly. But it's good to be prepared.
That's right. So as we wrap up here,
Mm-hmm.
what's that one key takeaway you want our listeners to walk away with today?
I would say, remember,
Yeah.
knowledge is power.
Knowledge is power.
Even a basic understanding of these injuries,
Mm-hmm.
recognizing those signs and symptoms, it can truly make all the difference.
It can be the difference between life and death.
Absolutely. Absolutely.
Wow. It's been an eye-opening journey
It has.
into a world that we don't often think about, but we really should.
We should.
That's all the time we have for today's deep dive.
Great chat.
Until next time, stay curious, stay informed,
Stay safe.
and stay safe. Ever tripped over absolutely nothing and just thought, well, there goes my ankle?
Or done something in a sports game and had that sinking feel.
Exactly. And that's what we're diving deep into today, musculoskeletal trauma. But this isn't some dry textbook lecture. Oh no, we're going for the need-to-know, the cheat sheet version.
We've got excerpts from this dense musculoskeletal trauma source.
And whether you're prepping for an exam or, like me, just morbidly curious about what happens when things go crack.
It's fascinating how often those everyday mishaps become complex medical situations.
Exactly.
Yeah.
So let's decode it all a bit. Now, the source jumps right into this ABCDE approach. Is it as simple as it sounds?
Deceptively so. It's the backbone of trauma care, that mental checklist. Imagine you're first on the scene. Airway. Can they breathe? Breathing. Are they struggling?
Yeah.
Circulation. Any major bleeding. Disability. Spinal injury. Unconsciousness. And finally, exposure. Getting a clear picture of the injuries.
So it's like triage for the body. Makes sense.
Exactly. You're tackling the most critical things first.
But then we move from that initial crisis to, okay, what's the damage? Broken bones, dislocations, all that fun stuff. And that's where I think those medical terms can get a bit intimidating.
Right, like open versus closed fractures.
Sounds simple enough.
Well, picture this, a simple crack where the skin's intact. Closed. But you've got bone poking out.
Yikes. Okay, that's an image that'll stick with me.
That's an open fracture, and it's a whole different ballgame.
So way more serious.
Absolutely, an orthopedic emergency, in fact. That open wound. It's an invitation for infection to get into the bone itself.
Hence the urgency. So what needs to happen right away in that situation?
The source really emphasizes this three-pronged approach. Sterile dressing on the wound, antibiotics to combat potential infection, and then you're looking at surgery, surgical debridement.
Okay, so cleaning out the wound, removing any damaged tissue to prevent things from getting worse.
Exactly. You want to control the situation as much as possible.
It makes you realize how crucial those initial actions can be. And speaking of things escalating quickly, the source also mentions something called compartment syndrome.
Now, that one does sound a bit like something from a medical thriller.
Right, so what is it?
Okay, so imagine your muscles are encased in this tight, inflexible sleeve, right? When pressure builds up within that compartment, it restricts blood flow to the area.
And that's bad because
Because it's like suffocating your muscles and nerves, which can lead to permanent damage if it's not addressed quickly.
So what should we be looking out for? How do you even know if it's compartment syndrome?
That's the tricky part. It might not always be obvious at first, but the source highlights some key things. Pain that seems way worse than it should, especially pain that intensifies when you stretch. You might also notice swelling, tightness, pale skin, a weak pulse in the area,
And in severe cases.
numbness, even paralysis.
Okay, definitely not something to ignore. What happens if you suspect compartment syndrome? Straight to the hospital.
You got it. Early diagnosis and treatment are key. Doctors can actually measure the pressure within the muscle compartment using a special needle.
Now, that sounds a bit intense.
It's quick, and the information it gives is crucial. The source mentions a pressure greater than 30 millimeters of mercury. That's when alarm bells really start ringing.
And if it is that high?
Then it's time for a fasciotomy.
Say that again?
A fasciotomy. It's a surgical procedure where they make an incision to relieve that pressure.
So, cutting open that inflexible sleeve you mentioned to give those muscles and nerves some breathing room.
Exactly. Restore normal blood flow, prevent lasting damage.
Wow. Well, it's incredible how those quick interventions can make such a difference. So, we've covered the initial ABCDE assessment, tackled the scary stuff like open fractures and compartment syndrome. What's next on our musculoskeletal trauma tour?
Now that we've laid the groundwork, it's time for an anatomical adventure. The source goes into detail about specific injuries, starting with pelvic fractures.
Ah, yes, those are the ones that can be life-threatening because of the bleeding, right? I've heard they use those specialized pelvic binders.
It's like a real-life superpower. Applying that binder can help control internal bleeding, which is absolutely crucial in those first critical moments.
Okay, that's definitely good to know. So we're about to embark on this whirlwind tour of the body, highlighting key points about different types of fractures and dislocations, from pelvis to pinky toe, or maybe the other way around. Where should we even begin?
Let's start with a bone that's surprisingly easy to break, the clavicle.
The clavicle? You mean the collarbone? I wouldn't have thought that was a common fracture.
You'd be surprised. They're incredibly frequent, especially after a fall or a direct blow.
You learn something new every day. So what's the typical treatment? Surgery?
Not always. The good news is that most midshaft clavicle fractures, the ones in the middle of the bone, can actually heal well with just a simple sling.
So no need for pins and plates, that's a relief.
Exactly. However, if the fracture is significantly displaced, meaning the broken ends aren't lining up properly, or if the bone is shortened, surgery might be necessary to make sure everything heals properly and the shoulder functions the way it should.
Makes sense. So moving down the arm, what about humerus fractures?
Those are interesting because they often come with a risk of radial nerve injury.
The radial nerve. See, now that sounds a lot more serious than a simple broken bone.
It can be. The radial nerve controls the muscles that extend your wrist and fingers, and it gives you sensation on the back of your hand. So if it's injured, you might experience wrist drop, the inability to lift your wrist, and decreased sensation in that area.
So it's not just about the broken bone itself, but also what that break might be doing to the surrounding nerves and what that means for everyday function.
Exactly. And it highlights why that thorough neurological exam is so important after any fracture. Now let's talk about a bone that's notorious for causing headaches and trauma. The scaphoid.
The scaphoid, isn't that a type of ship?
It is. And as it turns out, there's a tiny bone in your wrist, shaped just like a little canoe, also called a scaphoid.
No way. I had no idea. So what's the big deal with this little boat-shaped bone?
It's deceptively fragile. And because of its size and location, fractures are often missed on those initial x-rays.
Wait, seriously, you could have a fracture and not even know it.
It's possible, especially if the fracture is small or doesn't show up clearly. The VORS recommends playing it safe if they suspect a scaphoid fracture. They'll immobilize the wrist and might even do repeat x-rays later on to be sure.
Better safe than sorry, right? Especially with something as important as your hand. So from the subtle scaphoid, let's talk about a bone that's anything but subtle when it breaks: the hip.
Ah, yes, hip fracture is a major concern, especially as we get older.
It's one of those injuries you always hear about happening, especially in elderly individuals.
And for good reason. It's sadly quite common as we age, especially with conditions like osteoporosis weakening the bones. Even minor falls can become risky.
So what's the usual course of action with a hip fracture? Is it always surgery?
In most cases, yes. Surgery is needed to stabilize the fracture and allow for early mobilization. This can range from fixing the fracture with pins, plates, or screws to a full-on hip replacement, depending on the severity.
It's incredible what they can do these days. Okay, we've covered clavicle, humerus, that tricky little scaphoid. Now onto the hip. Are we ready to tackle the femur? I have a feeling that's a whole other ballgame.
The femur, or thigh bone, is the largest bone in the body, and femoral shaft fractures are definitely a big deal.
Just the name femoral shaft fracture sounds intense. What makes them so serious?
Well, for starters, they're often associated with significant blood loss.
Wow, okay. That definitely elevates the stakes. So what's the first line of defense in a situation like that?
Stabilization is key. and they'll often use a traction splint to do that.
Wait, a traction splint? Like what they show in those old medical dramas with ropes and pulleys?
It might sound a bit medieval, but it's incredibly effective. It helps stabilize the fracture, reduce pain, and minimize bleeding until they can get you into surgery.
So it's all about buying time to then address the underlying issue. It sounds like a well-choreographed dance between those initial life-saving measures and the surgical expertise. Speaking of which, what about knee dislocations? Those just sound excruciating.
They're certainly high up there on the pain scale, and they're considered true orthopedic emergencies. You see, there's this crucial artery that runs behind the knee, the popliteal artery.
And if that gets damaged?
It's not good. A damaged popliteal artery can compromise blood flow to the lower leg, and that's why knee dislocations need immediate attention.
So it's another race against time. Every second counts. What's the procedure for a knee dislocation?
The first step is to get that knee back into its proper position reduction. And the source really emphasizes the need to assess those blood vessels quickly, often using imaging.
It's amazing how interconnected everything is. You wouldn't think a dislocated knee would potentially involve blood vessel damage, but it makes sense when you think about it. Speaking of interconnected, let's talk about the tibia. As someone who's experienced my fair share of shin splints, I'm guessing tibial fractures are no walk in the park.
You're right about that. The tibia, or shin bone, definitely takes a lot of abuse. And tibial fractures, let's just say they often come with a side of soft tissue injuries.
Because the tibia is right there at the front, not a lot of padding.
Exactly. And we need to remember our earlier chat about compartment syndrome. Well, tibial fractures, especially those involving the top part of the shin bone that forms the knee joint, those have a higher risk of developing this condition.
So it's like this domino effect, one injury potentially leading to another. This is where it gets really complicated.
It does highlight why a comprehensive approach to diagnosis and treatment is so crucial.
You've got to look at the whole picture, not just the most obvious injury. Speaking of looking at the whole picture, what about foot fractures? Our poor feet, they take a beating every single day.
They do, and the source highlights one fracture that's notoriously painful. The calcaneus fracture.
The calcaneus, remind me again where that one is.
The heel bone.
Right, and now that you mention it, I can see why that would be incredibly painful. What usually causes a calcaneus fracture?
They often happen from falls. Stepping off a curb awkwardly, or in more severe cases, falling from a height. That impact sends a lot of force through the heel.
Ouch. Just thinking about it makes me want to walk on my tiptoes. So how do you even begin to treat a calcaneus fracture?
Well, they often need a CT scan because those fracture patterns can be pretty complex. Treatment depends on the severity and can range from immobilization in a boot or cast to surgery, particularly if the fracture involves the joint.
So it's not just a matter of slapping on a cast and calling it a day. It sounds like foot fractures, even if they don't seem as dramatic as a broken leg, can be quite complicated.
They can indeed. Now, before we wrap up our whirlwind anatomical tour, there's one more area we need to cover. The ankle.
Yes, the ankle. Another joint that's probably seen its fair share of mishaps. And I'm guessing there are a lot of different types of ankle fractures.
You're right. The source actually breaks ankle fractures down based on which malleoli are involved.
Malleoli. More new vocabulary. Refresh my memory here. What are malleoli?
Think about those bony bumps you can feel on either side of your ankle.
Right.
Those are your malleoli. You have one on the inside and one on the outside.
Okay, so those bony landmarks. Ankle fractures are categorized by whether you break one or both of those bumps.
Exactly. You can have a unimalleolar fracture where only one malleolus is broken, a bimalleolar fracture involving both, or even a trimalleolar fracture, which includes that bony prominence on the back of your tibia.
Wow, who knew there were so many ways to break your ankle? So how do they decide between surgery or something more conservative, like a cast?
It all comes down to stability. If the ankle joint is stable, meaning the ligaments are intact and the bones are lined up properly, a cast or a boot might be enough. But if it's unstable, surgery is often needed to realign the bones and stabilize the joint with plates and screws.
So it's not just about whether the bone is broken, but how that break impacts the stability of the entire joint.
Precisely. And managing musculoskeletal trauma often requires a whole team. Orthopedic surgeons, plastic surgeons if there's significant skin damage, vascular surgeons if there are blood vessel injuries, and of course those rehabilitation therapists to get you back on your feet, literally.
It's a team effort. We've covered so much ground today, but it occurs to me we've mainly focused on that immediate aftermath of these injuries. What about the long-term implications? What are some of the challenges people might face down the road?
That's an excellent point and a perfect segue into the broader context of musculoskeletal trauma, because the source doesn't just stop at that initial treatment. It gets into potential complications, long-term management, and the overall impact these events can have on a patient's life.
Okay, so let's dive into that bigger picture when we come back. We've definitely given our listeners a lot to think about already. All right, so we're back and ready to tackle those long-term challenges you mentioned. I have to admit, after that anatomical adventure, I'm already feeling a bit sore by proxy.
It's easy to focus on that immediate fix-it phase, but musculoskeletal injuries, they can have a lasting impact. And one concern the source highlights is this thing called post-traumatic arthritis.
Okay, so arthritis after a fracture. Does that happen with any type of break?
It's most common after those breaks that actually extend into the joint space, what we call intra-articular fractures. Imagine the smooth surface of a joint, like a well-oiled hinge. A fracture that disrupts that surface can really increase the risk of developing arthritis down the road.
So it's like those breaks never quite heal the same way, even if you do everything right.
That's a good way to put it. The source really emphasizes the importance of early recognition and management of this type of arthritis to slow its progression and maintain as much joint function as possible.
So it's another reason why that initial assessment is so crucial. What about other potential complications? I know infections can be a big concern with those open fractures we talked about.
Absolutely, and the source dedicates a whole section to a particularly nasty one, osteomyelitis.
Osteomyelitis. Okay, that sounds serious.
It is. It's an infection of the bone itself, and it can be really tough to treat, especially with those open fractures or if there are any foreign objects, involved.
That makes sense. How do they even begin to treat something like that?
Well, as we talked about earlier with open fractures, that immediate, thorough cleaning of the wound, the surgical debridement is absolutely essential. It's all about removing any contaminants that could lead to infection.
Get rid of anything that doesn't belong.
Exactly. And of course, antibiotics are crucial in treating and preventing these types of bone infections. They're like the heavy hitters in this scenario.
Okay, so we've got post-traumatic arthritis, we've got bone infections. Anything else we should have on our radar?
Well, there's also the issue of tetanus.
Tetanus, isn't that what you get from stepping on a rusty nail? Not exactly what I'd picture as, high-impact trauma.
It's true that rusty nails are often involved, but tetanus bacteria can actually enter through any open wound, including those from, you guessed it, fractures.
So even if it's not a rusty nail situation, you still need to be thinking about tetanus with any fracture.
Especially if someone hasn't had their tetanus shot in a while.
Yeah.
It's always better to be safe than sorry. And on that note of being proactive, there are some systemic complications we need to touch on as well.
Systemic complications, meaning they affect the whole body. Okay, this just got real.
They can be quite serious. One example the source mentions is fat embolism syndrome.
Fat embolism syndrome. That almost sounds like a medical mystery. What is that exactly?
So it's actually a potential complication after certain types of fractures, particularly those long bone fractures like a femur fracture.
The big one, yeah. But what's actually happening in the body?
Essentially, fat droplets from the bone marrow can escape into the bloodstream and travel to other parts of the body, the lungs, the brain, even the skin.
So it's like the body's own response to the injury is causing further damage. That's wild.
It is a bit of a paradox.
Yeah.
And those fat droplets can wreak havoc, causing breathing problems, confusion, even this characteristic rash.
Oh. Okay, what about this crush syndrome the source mentions? I have a feeling this is another one I don't want to experience firsthand.
Yeah, crush syndrome is definitely serious. It can happen when there's this prolonged compression of muscle tissue, like in a crushing injury.
I can imagine that would be a concern in a major accident. So what are the implications there?
The compressed muscles actually start to break down, and they release substances into the bloodstream that can damage the kidneys. You're talking about a whole cascade of potential issues, electrolyte imbalances, even cardiac arrest.
It's amazing how the body can be so resilient in some ways and yet so fragile in others.
Exactly. And that brings us back to the importance of that neurovascular assessment after any fracture or dislocation. We touched on it earlier with the radial nerve injury, but it's a crucial step in any musculoskeletal trauma evaluation.
So checking for pulses, capillary refill, that's the thing where you press on the skin and see how quickly the color returns, right?
Exactly.
And making sure there's normal sensation in the limb.
You got it. It helps determine if there's any damage to those blood vessels or nerves. And if there is, addressing it quickly can prevent long-term problems down the line.
It's another reason why those early interventions can be so crucial. But beyond the, physical complications, we also need to consider the emotional and practical challenges of recovering from these injuries.
100%. Musculoskeletal injuries can have a huge impact on a patient's quality of life. Chronic pain, limited mobility, difficulty doing those everyday tasks we take for granted, these things can really take a toll mentally and emotionally, not to mention the social isolation that can come with a prolonged recovery.
It's like this ripple effect impacting every aspect of your life.
Precisely. And the source really emphasizes a holistic approach to rehabilitation. It's not just about getting the bones and muscles back to a functional state, but it's also addressing those psychological and social aspects of recovery as well.
Treating the whole person, not just the injury. I love that approach. So we've covered a lot of heavy stuff today: potential complications, long-term challenges, the impact this can have on someone's life. It really makes you realize how important prevention is.
Absolutely. An ounce of prevention is worth a pound of cure, as they say. And that's where knowledge and awareness are so powerful.
Knowing the risks, taking steps to mitigate them, it seems like common sense, but it's easy to overlook those things until it's too late.
It's human nature to feel invincible until something happens, right?
Right.
But even those simple precautions can make a huge difference. Wearing proper safety gear when you're playing sports, being mindful of your surroundings to prevent falls, even just maintaining good bone health through nutrition and exercise.
Those are all such great points. But let's be realistic. Sometimes accidents happen. Life throws curveballs. So what can people do in those moments when an injury does occur to minimize the severity?
That's where having some basic first aid knowledge can really come in handy. Knowing how to apply a splint or a sling, recognizing the signs of a more serious injury that needs immediate medical attention, those are essential life skills.
I'm realizing how much I take for granted, just assuming someone else will know what to do in those situations.
It's never a bad idea to brush up on those skills, and don't underestimate the power of being your own advocate or advocating for a loved one in a medical setting. If something doesn't feel right, if you have questions, concerns, don't be afraid to speak up.
Being an informed patient is so important. I think we sometimes forget that we have a voice in our own healthcare.
Absolutely. And on that note of empowerment, I think it's time we transition to our final thoughts for today's deep dive. We've covered an incredible amount of information about musculoskeletal trauma today, from those first critical moments after an injury to the complexities of those different fracture types, the potential for complications, and of course that long road to recovery.
It's remarkable, really. I think we tend to think of a broken bone as so straightforward, but there's a whole world behind it.
There really is. Like we were saying, the impact, it goes way beyond that initial injury.
Absolutely. So for our listeners who might be feeling like they just aced a pop quiz on musculoskeletal trauma, what are the key takeaways you really want them to walk away with today?
Ooh, key takeaways. I like that. If I had to distill it down, I'd say awareness is paramount. Just understanding that musculoskeletal trauma, it's not a one-size-fits-all situation, it's a whole spectrum.
From a sprained ankle to, like we were talking about, something as serious as a hip fracture.
Exactly. And that actually leads us to the second takeaway, which is that early recognition. We've highlighted some of those red flags, severe pain, swelling, numbness, any difficulty moving a limb.
Don't hesitate to seek help.
Exactly. Trust your gut. If something feels off, it's always better to err on the side of caution.
Absolutely. And that actually brings us, I think, to our final key takeaway. And it might be the most important of all: prevention.
It really is. Like that old saying, an ounce of prevention is worth a pound of cure.
It really applies here, doesn't it?
Yeah, it does. We talked about wearing the right gear, being mindful of your surroundings to prevent falls, and taking care of your bone health with good old-fashioned nutrition and exercise. Simple steps.
But they can make such a difference.
They can.
Now, even with the best intentions, accidents happen. That's just part of life. So I'm curious, for our listeners who are now feeling super inspired, maybe want to learn more, what's something they could explore on their own? Something that we didn't quite have time to get to today?
Oh, that is such a good question. I think we've really delved into those physical aspects of these injuries, but what about that mental and emotional side of recovery?
That's so true. We often focus so much on that physical healing, but the mental and emotional recovery is just as important.
Exactly. So I would encourage everyone listening to dive into that aspect a little bit more. Look up some resources on managing pain, coping with the ups and downs of recovery, even the importance of social support during that time.
It's such a good point. That healing, it goes beyond just the bones and muscles. It really is about the whole person.
I think so.
And on that note of holistic well-being, I think we'll wrap up this deep dive. We've journeyed through the world of musculoskeletal trauma, from those first critical moments after an injury, to the importance of recognizing those signs and getting the right treatment, to that long road to recovery.
It's been such a pleasure exploring all of this with you.
Likewise. And to all of our listeners, thank you so much for joining us on this deep dive today. We hope you learned something new, that you gained a deeper appreciation for the amazing resilience of the human body, and most importantly, that you feel empowered to take charge of your own musculoskeletal health. So you wanted to know more about collapsed lungs, huh? Well, let me tell you. Digging into these medical journals, this stuff is fascinating. We're doing a deep dive on primary spontaneous pneumothorax, PSP for short.
Exactly. And we'll make sure it all makes sense, even if, medical jargon isn't your first language.
I appreciate that because honestly, PSP, it kind of sounds like something, well, made up, right? But from what I've been reading, it's like a serious thing where your lung just collapses, often without any warning.
That's the heart of it, yeah. PSP is all about a lung collapse that seemingly comes out of nowhere. Usually no history of lung problems or anything, well, at least not any obvious one.
Okay, see, that's what's so interesting to me. It's not like someone with, years of lung disease. This could just happen.
Well, not to anyone exactly. It's not totally random, if that makes sense. Most times there's some underlying weakness in the lung tissue, even if it's never been, diagnosed.
So it's more of a hidden vulnerability then, something that finally gives way.
That's a great way to put it. Think of it like a balloon, right? With a tiny flaw. Might look totally fine when it's blown up, but that weak spot's just there, waiting for, pressure to become a problem.
Okay, that makes sense, yeah. So it's not the blowing up the balloon part, but that almost invisible weakness that leads to the pop. And in this case, the pop is a collapsed lung.
Precisely. And just like with balloons, some people are, predisposed to these weaknesses, and certain factors can really make them more vulnerable.
And that makes me think about the demographics we saw in the research. For example, we found that PSP is way more common in men. I mean, the numbers in the US alone are kind of startling, over 7 times higher in men than women. What could explain that kind of discrepancy?
That is a great question, and one that researchers have been, trying to answer for years. The why is complex, but one factor definitely stands out more than the others.
Let me guess, it has something to do with lifestyle choices.
You're on the right track. Let's just say those invisible weaknesses in the lungs we talked about. They become a lot more common when you introduce a certain habit.
Okay, you're about to say smoking.
Yeah. Smoking is, it's a huge risk factor. And yeah, those numbers about men being more susceptible, a lot of that comes down to, smoking habits.
Yeah, the research we have cited that heavy smokers have 102 times higher risk of PSP compared to non-smokers. Wow, that's alarming.
It really is. And it all goes back to that balloon analogy. Smoking basically weakens the lung tissue, creating these tiny flaws, the ones that make a collapse more likely.
So it's like those microscopic tears you get in an overstretched balloon. You might not even see them at first, but they make it so much easier for the whole thing to just burst.
Exactly. Smoking makes the skin of the lungs, those delicate air sacs, more fragile, more prone to, rupture.
That's a pretty powerful visual. Okay, so smoking is enemy number 1 here. But what about those who've never touched a cigarette in their life? Are there other risk factors that they should be aware of?
Oh, absolutely. Family history, for one, plays a role. If someone has, a close relative who's experienced a spontaneous pneumothorax, they might be at higher risk.
Yeah, that makes sense. Genetics, they often play a part in these sorts of things.
Right. And there are also some specific genetic conditions that can up the risk, like Marfan syndrome, for example. It affects connective tissues all over the body, but also in the lungs.
So it's not just about the lungs themselves being weak, but the connective tissue that helps hold them together. Is that what you mean?
Precisely. And here's an interesting one. There's even a possible link between endometriosis and an increased risk of PSP.
Endometriosis. Now, that's not something you hear every day, in this context at least.
True. It's definitely an area that needs more research for sure, but some studies have shown, suggested a connection. It's like a reminder that even, seemingly unrelated conditions can sometimes have overlapping risk factors.
That's fascinating. Really highlights how interconnected our bodies are. But, okay. We've talked about who might be vulnerable, but how does this actually play out in real life? If someone is at risk for PSP, what are the warning signs?
Well, imagine this.
Yeah.
You're just going about your day, right? Maybe reading a book or watching TV. And then suddenly, bam, the sharp chest pain hits you, seemingly out of nowhere. That's a very common way it starts.
Oof, yeah. That sounds really painful. I can imagine it would be like terrifying to have that happen out of the blue. Is it always like a drop everything, call 911 immediately kind of pain? Or can it be, I don't know, more subtle?
It's a good question, and that's actually really important. It can vary quite a bit. The severity often depends on, well, the size of the pneumothorax, how much air has actually leaked into that space, between the lung and the chest wall. A small leak might just be like a nagging discomfort, you know what I mean? But a large one, that's going to get your attention.
So it's like if you want to use a real world analogy here, the difference between a small leak in your tire versus a full-blown blowout.
Exactly. And in those more serious cases, shortness of breath is another like major warning sign.
Okay, that makes sense. So sudden chest pain and shortness of breath, those are like the red flags to watch out for. But how is PSP actually diagnosed? What do they do?
A lot of people are surprised how straightforward it often is. A simple chest x-ray can usually spot a pneumothorax. It'll show that clear separation, where the lung is pulled away from the chest wall.
So no need for some like crazy complex lung decoding technology.
Thankfully not. A standard x-ray does the trick in most cases.
Yeah.
Though I will say the research we looked at also mentioned something called a tension pneumothorax, which that sounds a lot more serious.
It does. Yeah, that does sound kind of worrisome. What makes that type of pneumothorax, I don't know, different?
So it's a situation where basically the air that's leaked into the chest cavity, it starts to build up pressure. And that pressure, it can actually start to impact other organs, like the heart, for example.
Oh, wow.
And that's when it can become, a real medical emergency.
Yeah. That sounds like something you definitely want to catch early.
100%, which is why, going back to those warning signs we talked about, early diagnosis and treatment, really key here.
Speaking of treatment, what does that actually involve? Like if someone is diagnosed with PSP, what happens next?
Well, like a lot of things, it depends in this case on the severity. A small pneumothorax, it might resolve, entirely on its own, maybe just with a bit of monitoring and some supplemental oxygen. Think of it as like a chance for the lungs to, rest and repair.
Oh, okay. So like a bit of like enforced relaxation for the lungs.
Exactly. But for larger pneumothoraxes, doctors might need to intervene a little more directly.
And what does that intervention look like? What do they do?
So one option is, well, they call it needle aspiration, but basically it means using a needle to like draw the excess air out of the chest cavity, like almost like letting air out of a tire, to reduce the pressure.
And that helps the lung like reinflate.
Precisely. Sometimes a chest tube might be needed. It is, a bit more invasive, I suppose, but it allows for a more, controlled way to drain the air and let the lung re-expand.
And in those like more extreme situations, is surgery ever on the table?
Surgery is usually saved for those situations where the pneumothorax keeps, recurring, or if there's a persistent air leak that they can't seem to close, or in other cases, people in professions where a sudden collapse would be really dangerous, like pilots, for instance.
Oh, right. Yeah.
The surgery itself is often minimally invasive these days, and it basically aims to like patch up any weak areas to prevent future collapses.
So it's about like addressing the root cause and then sort of like reinforcing the lung to prevent it from happening, again and again.
Exactly. And that brings us, full circle back to prevention, which, as always, is the best medicine.
Yeah, couldn't agree more. And it sounds like just, from what we've discussed, being aware of those risk factors, especially, smoking, that's huge.
It really is. It's a good reminder, even though we're talking about a relatively uncommon condition here, the choices we make each day, those can have a real impact on our lung health.
Well, this has been, wow, really, really insightful. We've covered so much from like the signs that are so subtle all the way to treatment options. So thank you, a huge thank you for, guiding us through all of this. This is complicated stuff.
Happy to do it. Always love, digging into these fascinating corners of medicine.
And for everyone listening, we hope this deep dive has, given you a much better understanding of PSP. And hey, remember, knowledge is power, especially when it comes to our health, right? Until next time, stay curious.
All right, strap in everyone, because today's deep dive is about as critical as it gets. Shock.
Yeah, we're not talking about the I just saw the price of eggs kind of shock.
No, not even close, unfortunately.
We're talking about the medical emergency where recognizing the signs and knowing what to do can literally be the difference between life and death.
You've shared shock.txt with us, which seems to be quite the crash course in emergency medicine.
It is, and we're going to break it down so you come away feeling prepared, not overwhelmed.
Exactly. No defibrillators needed here. So when we talk about shock in a medical context, we're not just talking about someone feeling a little faint, right?
Yeah.
What's actually going on inside the body?
It's much more serious than just feeling faint.
Oh, yeah.
We're talking about a situation where your body's tissues and organs aren't getting enough oxygenated blood.
And that's a problem, obviously.
A big problem. You see, blood is essentially the delivery system for oxygen and nutrients that keep everything running.
Okay, so if the bloodstream is like the network of roads in a city, shock is basically like a major traffic jam.
That's a good way to put it. Without that steady supply of oxygen, cells can't do their jobs, organs start to fail, and things can go downhill quickly. Shock.txt uses the phrase inadequate tissue perfusion.
Right, inadequate perfusion, which essentially means those vital organs aren't getting the resources they need to survive.
Exactly. And to make things even more complicated, there isn't just one type of shock.
Oh, so it's not a one-size-fits-all situation.
Nope. The source we're looking at today, shock.txt, it highlights 4 main types of shock: hypovolemic, cardiogenic, distributive, and obstructive.
And knowing the difference is crucial because each type has different causes and needs a specific approach to treatment, right?
Absolutely. Recognizing what kind of shock you're dealing with can make all the difference.
So let's break down those 4 types, starting with hypovolemic shock. I'm hearing hypo, which makes me think of low volume, and volemic, which sounds a lot like volume. Am I on the right track?
You are.
Yeah.
Hypovolemic shock is the most common type, and it happens when there's a significant loss of blood volume in the body.
So like after a major injury or surgery.
Exactly. Severe bleeding is a classic cause, but it can also happen due to severe dehydration.
Because if you lose enough fluids, even without bleeding, your blood volume drops and your heart can't pump effectively.
Precisely. Your heart's working fine, but it doesn't have enough fluid to actually pump.
Like a car engine without enough oil.
Hmm.
It might be in perfect working order, but it's going to seize up without that essential fluid.
Exactly. Now, on the other end of the spectrum, you have cardiogenic shock.
Cardiogenic. That makes me think of the heart itself, right?
You got it. In this case, the problem isn't a lack of blood volume, but rather the heart's inability to pump effectively, even if there's enough blood.
So the pump itself is failing.
Exactly. Think of a massive heart attack that weakens the heart muscle or certain heart conditions that prevent it from doing its job.
Okay, so we've got 2 very different ways shock can develop.
Yeah.
Not enough fluid or a pump that's not working. What about distributive shock? That one sounds a bit more complicated.
It is a bit different. Distributive shock happens when the issue lies with the blood vessels themselves.
The blood vessels. So not the volume of blood and not the heart pumping, but the actual pipes themselves.
Exactly. In this case, the blood vessels lose their tone and become overly dilated. They get wider, which causes a drop in blood pressure, even if the heart is pumping just fine and there's enough blood volume.
So even if the pump is strong and there's plenty of water, the pipes themselves are too wide to maintain the pressure.
You got it. A prime example of this is septic shock, a life-threatening condition that can result from a severe infection.
Right, septic shock. And the infection basically causes this widespread dilation of blood vessels.
Exactly. And then we have a final type, obstructive shock, which is more straightforward.
Obstructive. Something's blocked.
You got it. Think of a massive blood clot in the lungs, a pulmonary embolism, or pressure on a major blood vessel from a tumor, for example.
So something's physically impeding the flow of blood, like a clog in a pipe.
Precisely. And just like with a clogged pipe, that blockage prevents blood from reaching where it needs to go, leading to, you guessed it, shock.
Wow, so we've got failing pumps, empty tanks, leaky pipes, and blocked passages. It's incredible how many ways this can go wrong. It is scary to think about how many things can cause someone to go into shock, and it seems like early detection is really key here.
It really is. Catching those early signs can literally make all the difference.
So we need to channel our inner medical detectives and be on the lookout for those clues. What exactly should we be looking out for?
Well, one of the first things you might notice is a rapid heart rate, what we call tachycardia in the medical world.
Tachycardia, so the heart starts racing.
Right. It's like the body's trying to compensate, trying to pump that blood faster to make up for the lack of oxygen.
Makes sense, like pushing on the gas pedal when your car is struggling to go uphill.
Exactly. Now, another key indicator is something called narrowed pulse pressure, which might seem a little less obvious.
Narrowed pulse pressure. Remind me what pulse pressure is again.
So, you know how blood pressure is measured with two numbers?
Systolic and diastolic, right?
You got it. Pulse pressure is simply the difference between those two numbers, the systolic, the top number, minus the diastolic, the bottom number.
Okay, so the gap between those two numbers tells us something important.
It does. A narrow pulse pressure, meaning a small difference between those two numbers, can indicate that the heart isn't pumping as effectively as it should be.
Interesting. So it's not just about how high the blood pressure is overall, but also how efficiently the heart is pumping with each beat.
Precisely. And along with a rapid heartbeat and narrowed pulse pressure, you also want to pay close attention to the skin, particularly in the extremities like the hands and feet.
What should we be looking for?
Cool and clammy skin is another big red flag.
Because the body is trying to conserve heat and direct blood flow to the most vital organs.
You got it. And then there's something called delayed capillary refill, which is a fancy way of saying.
That thing where you press on someone's fingernail and see how long it took for the color to return?
That's the one. If the color doesn't come back quickly, it suggests poor blood circulation. And we can't forget about the brain, which is very sensitive to oxygen levels.
Right. The brain needs a constant supply of oxygenated blood to function properly.
Exactly. And changes in mental state can be a warning sign that something is wrong.
So someone who's confused, disoriented, or not acting like themselves.
Exactly. Shock.txt really emphasizes how those changes in mental status, whether it's anxiety, restlessness, or even just seeming a bit off, should always be taken seriously.
It sounds like recognizing shock is all about connecting those dots, taking all these different signs together to get the full picture, right?
It absolutely is. It's like putting together a puzzle. One piece by itself might not tell you much, but when you start putting them all together, you get a much clearer picture.
And that's where that trust your gut factor comes in, right?
Exactly. Sometimes your intuition picks up on something that your conscious mind hasn't quite processed yet.
So even if we don't know exactly why, if something feels off, we should trust that instinct and seek help immediately.
Absolutely. Don't ever hesitate to call for help if you suspect someone might be going into shock.
It's definitely a good reminder to trust those gut instincts, better safe than sorry, especially in an emergency. But let's say someone IS showing those signs of shock. We've called 911, but every second counts. What can we do while we're waiting for the paramedics to arrive?
Well, the absolute first priority, as always, is making sure the person can breathe. Airway, breathing, circulation, the ABCs. Shock.txt really drives that point home.
And the circulation part often involves getting fluids into the bloodstream as quickly as possible, right?
Exactly. We call that fluid resuscitation, and it's often the first line of treatment for shock.
So basically giving the circulatory system a boost by replenishing those fluids.
You got it. Shock.txt specifically mentions using what we call crystalloid solutions fluids like normal saline or lactated ringers to quickly increase blood volume.
So the goal is to get that blood pressure back up to a normal level, ASAP.
Well, it's actually a bit more nuanced than that. We don't always aim for normal blood pressure right away, especially in cases of trauma.
Really? Why not?
Think about it. If someone's bleeding internally and we raise their blood pressure too quickly, we might dislodge any clots that are trying to form, which could make the bleeding worse.
So it's about finding that balance.
Right.
You need enough blood pressure to keep the vital organs supplied, but not so much that you worsen the underlying problem.
Exactly. And shock.txt talks about a strategy called permissive hypotension, which is basically allowing the blood pressure to stay a little lower than you might expect for a short period to avoid making things worse.
So sometimes less is more in those initial stages. Fascinating how counterintuitive these things can be.
Absolutely. And a similar philosophy applies to the concept of damage control resuscitation, which is all about prioritizing the things that will stabilize the patient and minimize further damage, even if it means delaying certain interventions until they're more stable.
It sounds like emergency medicine requires a remarkable amount of both knowledge A&E adaptability.
It really does. You have to constantly assess, reassess, and adjust your approach based on the individual situation. And of course, we've been focusing on the basics here, but managing severe shock often involves more advanced interventions that require the expertise of trained medical professionals. Shock.txt mentions things like monitoring lactate levels and base deficit, administering blood transfusions.
And using medications like tranexamic acid PXA to help control bleeding.
Right, all tools that can be incredibly effective but require specialized knowledge to use safely and effectively.
Absolutely. And speaking of specialized knowledge, are there any unique considerations when it comes to recognizing and managing shock in specific populations, like children or older adults?
That's a great question, and it's something shock.txt touches on. Children, for example, can be particularly tricky because they have a remarkable ability to compensate in the early stages of shock.
So they might seem surprisingly okay at first, even if they're in serious trouble.
Exactly. Their bodies are great at masking the signs, at least initially, but then they can deteriorate very quickly if the underlying problem isn't addressed.
That makes it even more important to be vigilant and not downplay any potential signs of shock in kids. What about older adults? Any special considerations there?
Absolutely. Older adults often present differently than younger adults. They might not have the same textbook signs, or they might have underlying health conditions that complicate the picture.
So it all comes back to that individualized approach, considering the person's age, medical history, and the specific circumstances.
Exactly. There's no one-size-fits-all approach to managing shock. But if there's one thing I hope our listeners take away from today's deep dive, it's this. Early recognition is key. Knowing the signs and trusting your instincts can truly save lives.
Absolutely. And I think that's a great note to end on. We've covered a lot of ground today, but if there's one thing you should remember, it's this. Shock is a serious medical emergency, but with knowledge and quick action, the outcomes can be much better. So stay curious, stay informed, and as always, stay safe out there. All right. Ever thrown your back out trying to open a pickle jar?
Yeah, me too. Back pain, it's practically universal, right?
Right.
But today, we're not talking about the everyday aches and pains. We're strapping in
Oh, yeah.
for a wild ride into the world of spinal trauma.
Yeah.
We're talking the kind of serious stuff that makes you instinctively grab your own neck just thinking about it. Car accidents, falls, you name it. And we've got a stack of sources here
We do.
that break down everything from how these injuries actually happen
Yes.
to the potential long-term consequences.
That's fascinating.
Yeah,
actually.
I bet.
Yeah.
And it's those potential consequences, I imagine,
Yes.
that make spinal trauma so different from just your everyday, sore back.
Absolutely, because we're not just talking about discomfort here, but potential damage to the spinal cord, the information superhighway of your entire body.
And that's what makes this whole assumed spinal injury thing so crucial.
Agree.
Yeah.
Yeah.
Our source really emphasizes that first responders, that's like rule number one for them.
Absolutely.
But why is that assumption so important? I mean, it's not like every bump and bruise means you've got a spinal injury, right?
Well, you'd be surprised, actually.
Okay.
Think of it this way. Imagine if a major highway suddenly shut down.
Okay.
Traffic backs up, communication breaks down, everything grinds to a halt.
Right.
That's essentially what happens with a spinal cord injury.
Wow. Okay.
It's not just about the bones, it's about what those bones are protecting.
Okay. That's a visualization I won't soon forget. Speaking of which, the source got really detailed about the actual structure of the spine
Yes.
with all its different regions, the cervical, thoracic, lumbar, sacral. I mean, it's like a bone tower with its own zip code.
It's true.
And to be honest, it's a lot more complex than I ever imagined.
Right.
Why all the different sections? What's the deal with that?
It's all about function.
Oh, okay.
Each of those regions, your cervical, your thoracic, lumbar, sacral, coscidiscs, each of those has its own unique job to do,
Right.
which also means it can be injured in its own way. It's like how a sports car is built for speed and a pickup truck is built for hauling both vehicles, but very different vulnerabilities.
So the type of injury then depends on which part of the car gets hit, so to speak.
Exactly.
Which brings us to the how. And forgive the pun, but this is where it gets really spine-chilling. Our source calls this section mechanisms of injury. And it's basically a playbook for how these injuries actually happen. And let me tell you, some of this stuff is like watching an action movie gone wrong.
It is. It's about understanding the vulnerability that's hidden within that strength.
Okay.
So take axial loading, for example.
Okay.
Imagine a diver landing headfirst into a too shallow pool. That force compresses the vertebrae with such intensity that it can actually fracture them.
Ouch. Yeah. That's a hard one to imagine. It's amazing how something we see as, like, fun, can be so dangerous.
Exactly. Or think about whiplash.
Right.
That sudden jolt back and forth like in a rear-end collision, that's a recipe for severe extension and flexion of the neck, potentially damaging those delicate structures.
And those are just a couple of examples.
Right.
Our source also talks about rotation,
Yes.
like in a twisting sports injury,
Sure.
or penetrating trauma, which, sounds exactly as scary as it is.
It can be.
But you mentioned something earlier that really stuck with me, and that's the vulnerability of those C1 and C2 vertebrae. What makes those two so different? They're just at the top of the neck, right?
They are. But it's their location that makes them so crucial.
Okay.
They're literally holding up your head and protecting the brainstem,
Right.
the control center for, all your vital functions. Damage up there, it isn't just painful.
Right.
It can be instantly life-threatening.
Okay, now those are the kind of details that make you want to wear a helmet 24/7.
Right.
Really puts things in perspective.
It does.
Knowing how a seemingly minor injury in the wrong spot can have such a major impact.
Exactly.
Wow.
And those C1, C2 injuries are just one example of how devastating spinal cord damage could be.
Right?
So let's kind of delve into the different ways these injuries actually manifest.
Okay.
Because our source makes a distinction between complete and incomplete spinal cord injuries.
Okay.
And to be honest, those terms always sound a little clinical to me.
Right. Like, what does that actually look like for a person experiencing it?
Yeah.
Is it as simple as complete meaning total damage and incomplete meaning, like, things aren't so bad?
It's a good place to start, but the reality is far more nuanced.
Okay.
Think of it this way, with a complete injury.
Yeah.
It's like the communication line between your brain and the body below the injury is completely severed. No signals are getting through.
Wow.
But with an incomplete injury, it's more like some of those signals are still getting through,
Okay.
just in a jumbled or weakened state.
So instead of a clean break in the cable, it's more like some wires are frayed or crossed.
That's a great way to put it.
Okay.
And depending on which wires are affected, the symptoms can vary wildly.
Oh, interesting.
Our source goes into a bunch of these specific syndromes, and some of them are pretty mind-blowing.
Okay, well, lucky for me, you're basically a walking, talking neurology textbook, so hit me with it. What are some of these syndromes and what makes them so different?
Let's start with anterior cord syndrome.
Okay.
This one typically happens from a flexion injury. Imagine someone having a really bad fall and landing on their chin, compressing the front of their spinal cord.
Yeah, I can picture that, unfortunately.
So because of how the spinal cord is structured,
Okay.
damage to that anterior part, or the front part, disrupts motor function.
Okay.
So movement and things like pain and temperature sensation below the injury.
Wait, so you might not feel a hot stove or know where your legs are in space.
You got it.
Wow.
But here's the thing.
Okay.
Light touch and proprioception, which is basically your sense of body position,
Right.
might still be partially intact.
Interesting.
So someone with anterior cord syndrome might not be able to move their legs,
Right.
but they could still feel a gentle touch on their skin.
That is wild. So it's not as simple as everything below the injury being gone. It's way more specific than that.
Absolutely. And to make things even more fascinating,
Okay, lay it on me.
let's talk about Brown-Sequard syndrome.
Okay.
This one often results from penetrating trauma, like a stabbing,
Okay.
where only one side of the spinal cord is damaged.
Okay, so very different from the fall we were just talking about.
Right.
Got it.
And because of how nerve pathways cross over in the spinal cord,
Okay.
we see something called ipsilateral and contralateral effects.
All right, hold up. Those are some $10 words.
Chuckles.
Break it down for me.
Sorry. Ipsilateral just means same side.
Okay.
Contralateral means opposite side.
Okay.
So with Brown-Sequard, you might lose motor function on the same side as the injury,
Okay.
but lose pain and temperature sensation on the opposite side of your body.
Wait, so if you were unfortunate enough to touch that hot stove, you'd feel it in the hand that couldn't even move to pull away. Oh my God.
It's like the signals got their wires crossed in the most unfortunate way possible.
Wow.
It's one of the things that makes spinal cord injuries so complex to diagnose and treat.
I can only imagine.
Right.
Okay, so we've got these different ways an injury can happen.
Right.
And then all these variations in how the injury itself actually affects the body.
Yes.
It really drives home how this isn't a one-size-fits-all kind of thing.
You got every case is unique, which is why early diagnosis and a tailored treatment plan are absolutely critical.
Which brings us to, I guess, the what happens next phase.
Right.
Our source goes through this whole journey from the initial emergency response
Yes.
all the way to long-term rehab.
Right.
And let me tell you, some of that ER stuff sounds intense.
Yeah.
They mention this like log roll technique for moving someone with a suspected injury.
Mm-hmm.
It almost sounds like something out of a spy movie.
Right.
What's the deal with that?
It is, yeah. It's all about minimizing movement.
Right.
Like they're treating the spine like a fragile artifact.
Yeah, exactly.
One wrong move could cause more damage.
Right.
So the log roll, it's all about moving the patient as a single rigid unit,
Oh, wow.
keeping their spine perfectly aligned.
Okay.
It's a delicate dance. It takes a whole team to pull it off safely.
Oh, I bet.
And that's just the beginning.
Right.
Imaging is crucial.
Mm-hmm.
X-rays, CT scans, MRIs, they're all tools to help us see the full picture of the injury.
It's like detective work, but for your spine.
There you go.
Speaking of detective work, I was really surprised by the sources section on high-dose steroids. They're often used in other types of trauma, but here it sounds like they're more of a controversial topic.
Yeah, and it really comes down to, you see, steroids like methylprednisolone.
Right.
They can help reduce inflammation in the spinal cord after an injury,
Okay.
which in theory could limit further damage.
Right.
But there's a catch.
Okay, what's the catch?
Potential side effects.
Okay, so it's not just a simple, like, give everyone steroids situation.
Not at all.
Got it.
It's a delicate balance between potential benefits and risks.
Right.
We're talking increased chance of infections, gastrointestinal bleeding, even lung complications.
Wow.
The decision to use them is complex,
Yeah.
individualized, and still hotly debated in the medical community.
Wow. So it's not just about fixing the immediate injury, it's about making sure the cure isn't worse than the problem itself.
Exactly.
That's a tough one. But let's say that initial crisis is over.
Okay.
What comes next?
That's when the focus shifts to the long game,
Okay.
rehabilitation.
Okay.
And we're not just talking about physical therapy here.
Right.
Although regaining strength and mobility, obviously a huge part of it. It's also about occupational therapy,
Okay.
learning to adapt to daily tasks, reclaim independence.
So regaining that sense of autonomy.
Exactly.
And what about the psychological aspect of this? I mean, this isn't just a physical injury.
Right.
This is a life-altering event for a lot of people.
Absolutely. The psychological and emotional toll of a spinal cord injury can be immense.
Right.
So therapy, support groups, a strong support network.
Right.
These are all crucial. We're talking about helping people navigate a new reality, not just recover from a physical setback.
You know, reading through all of this, the thing that really got me was the section on pediatric spinal injuries.
Okay.
They mentioned something called CCORA, which it's an acronym, of course, because medicine loves those.
Of course.
It stands for spinal cord injury without radiographic abnormality.
There you go.
It sounds like a medical riddle to me.
It does, doesn't it? But it's a very real phenomenon.
Right.
And it highlights just how crucial a thorough evaluation is, especially in children.
Okay.
Basically, CCORA means there's neurological damage to the spinal cord,
Okay.
but standard x-rays don't show any obvious fractures.
So a kid could be showing all the signs of a serious injury, but the x-ray comes back perfectly normal.
That's exactly it, and it's why we can't rely on imaging alone, especially in kids.
Right. Gosh, that's scary.
It is. A child's spine is still developing,
Right.
making it more flexible and unfortunately more prone to these types of injuries.
Of course.
That's why a high index of suspicion, a detailed neurological exam, and potentially an MRI are essential in these cases.
It really drives home that whole always assume spinal injury idea we talked about earlier.
Yes.
Better safe than sorry, especially when we're talking about a child's developing spine.
Absolutely. And it brings us to, I think, a larger question
Okay.
that I hope our listener will ponder even after this deep dive.
Okay, what's that?
Knowing how prevalent spinal cord injuries are, how complex the treatment and long-term impact can be,
Right.
how can we as a society improve?
Wow, that's the million-dollar question, isn't it? Where do we even begin?
It's multifaceted, right? Of course, research into new treatments
Right.
and hopefully a cure is crucial.
Of course.
But we also have to think about prevention
Right.
and advocating for better safety measures, from stricter seatbelt laws to safer equipment for sports.
Right.
And we can't forget about raising awareness.
Right.
The more people understand the very real risks associated with spinal trauma, the better we can protect ourselves and our loved ones.
It's a call to action for all of us, really, to be informed, to be proactive, and to be compassionate towards those living with these life-altering injuries.
Well said.
Well, on that note, I think we've given our listeners a lot to think about today. We've covered everything from the anatomy of the spine to the complexities of treatment, the emotional toll, and the importance of ongoing research and support.
It's been quite the journey. We really went deep on this one.
We did. We went deep. So to our listeners, we hope this deep dive has been informative and engaging, but also empowering.
Absolutely.
Knowledge is power, after all, especially when it comes to something as crucial as spinal health.
Could agree more.
Well, until next time, thanks for joining us for the deep dive. Ever scorched yourself on a hot pan? You know when you're not sure if that sizzle is the food or your skin?
Oh, yeah.
Makes you wonder if it's actually sizzling.
Right.
Turns out it kind of is, and that's just the tip of the iceberg when it comes to thermal burns.
That's true.
So today, we're diving deep into the world of burns, and I mean really diving deep, beyond just the what, but the fascinating why behind how these injuries happen, and more importantly, what you can actually do about them.
Sounds good.
And to guide us through this fiery topic, we've got our resident burn expert.
Resident, I like that. I wouldn't say I'm an expert, but burns are definitely a passion. And honestly, you'd be surprised how many misconceptions people have about something we encounter so often.
Oh, absolutely. And that's what makes this deep dive so important.
For sure.
We're going beyond basic first aid here.
Yeah.
We're giving you the knowledge to really understand what's going on.
I like it.
But before we get ahead of ourselves, let's start with the fundamentals. Can you give us a quick rundown of what exactly a thermal injury is?
Sure.
And how it's different from those other types of burns we hear about?
Absolutely. So a thermal injury, put simply, is a burn caused by heat.
Okay.
And that heat can come from anything. A hot stovetop, scalding hot liquids, even friction, like a rope burn, believe it or not.
Oh, wow.
Yeah, it all boils down to the transfer of heat energy to your skin and the damage that it causes.
Makes sense.
Now, this is different from, say, a chemical burn,
Okay.
where it's not heat, but a corrosive substance actually causing the damage through a chemical reaction.
Right.
Or electrical burns, which have their own whole mechanisms, but we won't get into that today.
So it's like the difference between getting a sunburn and then like accidentally splashing bleach on yourself.
Exactly.
Both bad.
Both bad news.
But two totally different beasts. Right.
Totally.
Now, within thermal burns, I know there's like a whole classification system.
Right.
Based on the severity, the first degree, second degree, all that.
Uh-huh.
Can you walk us through those different degrees and what actually distinguishes them?
You got it. So it all comes down to the depth of the burn. First degree, think your typical sunburn. Red, painful, but it's only affecting that top layer of skin.
Okay.
Second degree burns, they go a little deeper. They're the ones that cause those blisters.
Yeah.
And that kind of weeping look. That's actually fluid leaking out as your body tries to heal.
Ah.
Now, this is where it gets a little tricky.
Okay.
Third degree burns, those obliterate the entire thickness of the skin. And they can look, this is the thing, they can look deceptively dry, leathery, sometimes even white or black. And here's the kicker. They often feel numb because the nerve endings are destroyed.
So no pain doesn't always mean no problem.
Exactly. Absence of pain with a burn, that can actually be very dangerous because it might mean that the injury is much deeper than you think.
I see.
Now, fourth degree burns, thankfully, much rarer.
Okay.
These are the ones that go beyond the skin,
Oh, wow.
into the muscle, tendon, even bone.
That's intense.
Yeah, those require immediate specialized care, obviously.
Absolutely. Now, you mentioned the depth of the burn, but what about the size, like the area of the body that's affected? Right.
I've always been curious about those medical terms.
Yeah.
The rule of nines, the Lund-Browder chart.
Yeah.
How do those play into assessing the severity?
So those are more for precise medical calculations,
Right.
but if you're trying to estimate in everyday life,
Right.
think of your handprint.
Okay.
That's roughly about 1% of your body's surface area. So if the burn is the size of your palm, that's about 1%. Twice that, 2%. Just a handy little visual to gauge severity.
That's a fantastic tip.
Yeah.
I'm adding that to my mental first aid kit right now.
There you go.
So let's say we've assessed the situation. We kind of know what we're dealing with. What are the absolute first things we need to do if we or someone around us, experiences a thermal burn?
Right.
I think everyone wants to know those crucial ABCDEs of burn first aid. Yes, Yes, knowing what to do immediately is absolutely crucial. It can make all the difference. And it all starts with airway.
Okay.
This is especially important in situations like fires, where smoke inhalation might be a risk.
All right.
So is the person able to breathe clearly? Can you hear any weird sounds? Then it's B for breathing.
Okay.
Are they taking breaths that look like they're normal, nice and deep and at a regular rate?
Got it.
Then C, circulation. Check their pulse. Is the blood flowing?
Okay.
D is for disability. Are they conscious, alert, responsive? Can they talk to you? And finally, E, this stands for exposure and environment.
Okay.
Remove any clothing or jewelry near the burn, and obviously get them away from any further danger, any heat sources.
Get them out of harm's way.
Exactly.
Okay, so we've got our ABCDEs down. We've assessed the situation. We're thinking clearly. What are the actual hands-on things we need to do next?
So once you're sure that the person is stable, airway, breathing, all that, your absolute first priority is to halt the burning process.
Yeah.
Seems obvious, but in the heat of the moment, pun intended,
Right.
people forget.
Yeah.
Remove them from the heat source. Douse any flames. Anything to stop that heat energy from continuing to damage the skin.
Get the situation under control. It makes me think of those fire safety videos, like stop, drop, and roll, because you really don't think straight when you're panicking.
Exactly. And then comes the part that I think everyone has heard of.
Yeah.
Cool the burn. Cool. Running water for a solid 20 minutes. And I do want to emphasize cool, not freezing.
Okay.
Ice might seem soothing in the moment, but here's the science. Extreme cold constricts your blood vessels.
Okay.
That restricts blood flow, which can actually worsen damage to the already injured tissue.
So that's why no ice?
Exactly.
It's kind of counterintuitive.
It is.
But it makes perfect sense when you explain the why.
Right. Your body needs that blood flow to start the repairs. Now, once you've cooled the burn, you want to cover it loosely with a sterile nonstick dressing. And please, ditch those home remedies.
Okay.
The butter, the oils, I know, grandma swore by it, but those things trap heat and they increase the risk of infection.
No butter on burns. Got it.
No butter.
Speaking of those kind of old wives' tales, what are some other, first aid myths that we should just debunk right here, right now?
Oh, where to begin? Okay, toothpaste.
Yeah.
It's abrasive and actually not helpful at all.
Great.
Breaking blisters.
Yeah.
Don't do it. Those are protective barriers.
Okay.
Like little internal bandages.
Okay.
And for the love of all things sterile, no picking, no poking at the burn.
Right.
Infection is a serious risk with burns, and that's why that proper wound care is crucial.
It all comes back to understanding that why, doesn't it? It's like we're not just trying to memorize steps. We're trying to understand the reasoning behind them so we can actually act confidently in that stressful situation.
Exactly. And speaking of understanding the why, I know you wanted to move a little beyond just that initial first aid
Yeah.
to dive into some more specific burn scenarios.
Right.
You had some questions about inhalation injury.
I did. This is where it gets really interesting for me because now we're thinking about what's happening inside the body. So what is it that makes inhalation injury so dangerous beyond, the burn itself?
So it's all about the airway, which, as we said, is priority number one. Inhalation injury, that happens when you breathe in hot air or smoke, and it damages your respiratory tract. This can cause swelling, inflammation, and in really serious cases, completely obstruct the airway.
It's like an invisible injury that's happening deep inside where you can't see it.
Exactly.
That's terrifying.
It is. That's why that immediate action is so crucial, even if you don't see external burns on someone who's been rescued from a fire. Getting them to fresh air, checking their breathing, and calling 911 immediately is vital. Severe cases might even need a tube inserted into the trachea to keep that airway open, a procedure called intubation.
Wow. And this ties into those other dangers we hear about with fires. Carbon monoxide poisoning, cyanide poisoning.
Right.
Can you talk a little bit about those?
Absolutely. So carbon monoxide, that's a colorless, odorless gas, and it's released during combustion. Think of your red blood cells like tiny little buses carrying oxygen throughout your body.
Okay.
Well, carbon monoxide, it's like a passenger that pushes oxygen off the bus, essentially suffocating you from the inside out. You might not even realize what's happening until it's too late.
That's a chilling way to put it.
Yeah,
But it definitely gets the point across.
it does.
And what about cyanide poisoning?
So cyanide, that's often released from burning synthetic materials. And while it's thankfully less common than carbon monoxide, it's equally dangerous.
Okay.
It interferes with how your cells use oxygen and leads to really rapid cell death.
So it's not just the flames we have to worry about in the fire. It's these invisible threats as well.
Exactly. That's why working smoke detectors, escape plans, and knowing basic fire safety is so important.
Absolutely. Now, shifting gears a bit, I wanted to talk about fluid resuscitation.
Okay.
I came across this idea of the Parkland formula in my research.
Right.
And while I don't need to calculate it on the spot or anything,
Sure.
I am curious about the concept.
Yeah, great question. So severe burns, especially those that cover a large surface area, they cause you to lose a massive amount of fluid through the damaged skin.
Really?
It's like your body's trying to cool itself from the inside out.
Yeah.
But it can lead to dehydration, shock, even organ failure. Imagine a bucket with a hole in it, right?
Yeah.
That represents the fluid loss. The Parkland formula, that helps the medical professionals calculate precisely how much fluid to pour back in intravenously based on the patient's weight and the extent of their burns.
So it's about replenishing those lost fluids and preventing the body from going into crisis mode.
Exactly. And while the exact calculations are definitely for medical professionals, the takeaway for our listeners is this. If someone with a significant burn isn't producing enough urine, that is a major red flag that their fluid levels are off and they need immediate medical attention.
Okay, so that's a very tangible thing to watch out for.
Yes.
And this all ties into burn shock, right?
You got it. Burn shock is essentially a form of hypovolemic shock, meaning low blood volume caused by, you guessed it, severe burns. Remember our bucket analogy? When your blood volume drops too low, your organs don't get enough oxygen and things can really spiral downward quickly. That's why that early aggressive fluid resuscitation is absolutely crucial in managing burn shock. It's like giving your body's internal fire trucks enough water to put out the fire.
We've covered a lot of ground here.
We have.
From the immediate aftermath of a burn to all these internal chain reactions we might not realize are even happening.
It's a lot to think about.
It is. And speaking of things we might not realize, let's tackle some of those persistent myths about burn treatment.
Oh, yes.
We already debunked butter, toothpaste, ice.
Right.
But I'm sure there are more out there.
Oh, there are always more. One I hear a lot is using vinegar or baking soda.
Okay.
And while those things have their uses when it comes to burns, they can actually irritate the wound and do more harm than good.
So what's the harm in trying these home remedies? If they don't help, what's the worst that could happen?
Delaying proper treatment is the biggest risk.
Okay.
These home remedies might make you feel like you're doing something, but they could be interfering with the healing process. And with burns, sometimes doing nothing is better than doing something wrong.
That's a really good point.
Yeah.
So when is it time to say, okay, this is beyond my expertise. I need to get some professional medical help.
Right.
What are the signs?
Well, remember that handprint analogy we talked about for burn size?
Yeah.
Any burn larger than your palm definitely warrants a professional evaluation. Also, full thickness burns, even if they're small, need a doctor to look at them. And of course, any burn to the face, hands, feet, genitals, over joints, those should all be assessed by a medical professional, just because of the potential for complications.
Yeah, those areas are so sensitive. So size, location, depth of the burn, those are all key factors.
Yeah.
What about symptoms? Are there any red flags where it's get to the hospital now?
Absolutely. Difficulty breathing, any altered mental state, signs of shock, pale skin, confusion, those are all major red flags.
Gotcha.
And if the pain just isn't manageable with over-the-counter pain relievers, that's another sign to seek medical attention.
This has been, honestly, incredibly eye-opening. But before we wrap up, I think it's important to acknowledge the psychological and emotional side of burns.
Oh, absolutely.
These aren't just physical injuries. They can leave lasting emotional scars as well.
You're right. The emotional and psychological toll of burns is often underestimated. I mean, imagine the anxiety of dealing with this painful injury, the potential for scarring, the trauma of the event itself. It can really take a toll on anyone.
And it's so crucial to remember that healing goes beyond just the physical.
Yes.
Seeking support, whether that's from mental health professionals, support groups, that's just as important as treating those physical wounds.
I completely agree. Support groups can be incredibly beneficial. They provide a safe space for survivors to connect and share their experiences.
On that note of support and resilience, I want to leave our listeners with a message of hope. The human body has this incredible capacity to heal. And with the right care and support, even severe burns can be overcome.
It's amazing to see, actually, that resilience of the human spirit, especially in the face of such trauma.
This whole deep dive has really been about empowering you, our listeners,
Yes.
with knowledge. We went from the basics of what a burn even is all the way to managing the aftermath and understanding these long-term implications.
And remember, knowledge is your best defense here. Understanding burn injuries, understanding the first aid, it can make all the difference in those crucial moments.
Absolutely. Now for that final thought, and this one hits home for me. Take a moment to think about fire safety in your own home. Do you have working smoke detectors? Do you have planned escape routes with your family? A fire extinguisher readily available? And just as important, do you know how to use it? These simple precautions can prevent so many tragedies.
Couldn't agree more. Being prepared is key.
And on that note, we'd love to hear from you. Have you or someone you know experienced a burn? Sharing your stories can help others be more prepared. Find us on our website or social media. Until next time, stay curious, stay informed, and stay safe. Okay, so we've all heard those jokes, right? About becoming, accident prone as we age, tripping over air, bumping into things.
Oh,
What's just a senior moment? Everyone laughs. But this document you sent me on geriatric trauma, it's really got me thinking differently. It's pretty serious stuff.
It really is. It kind of flips the script on that whole dismissive view. It's less about laughing off stumbles and more about realizing there are these really complex physiological changes happening underneath that we don't always see.
Exactly. It's like we're seeing the senior moment, but not the why. And that why can make a huge difference.
Absolutely, because those changes, they make older adults so much more vulnerable to serious injury.
Yeah.
Even from what seem like, pretty minor things to the rest of us.
Yeah. One phrase in this document really jumped out at me. Decreased physiological reserves. What does that actually mean? It sounds like, I don't know, my car when the check engine light's on and it's running on fumes.
Okay, I like that analogy. Think of it this way, like your body's systems, they're all running on a battery backup.
Okay.
But as we get older, those batteries, they just don't hold the same charge anymore.
Ah, I see.
And they're slower to recharge. So the heart, the lungs, even how efficiently we stop bleeding, it all becomes a bit less high performance, we'll say.
Yeah.
Where a younger person might bounce back quickly, an older adult's body.
It's like it's working with less backup to begin with.
Exactly.
So it's not just that bones get more brittle, it's like the whole system is less resilient, right?
Yeah. Precisely. This source material, it talks about how aging affects things like cardiac output, how well your heart pumps blood. There's less oomph to compensate for blood loss, so older adults are much more susceptible to shock.
Wow, even from seemingly minor injuries, you're saying?
Even from things that, a younger person might just walk away from.
That makes the document's point about lower thresholds for trauma centers make a lot more sense. It's not overreacting, it's realizing just how quickly things can become serious.
Early intervention, it is absolutely critical in geriatric trauma because what's happening on the outside, it's not always the full picture.
Right, and speaking of not getting the full picture, the document also goes beyond the immediate injury to talk about things like pre-existing conditions, medication effects, stuff that might not be obvious, especially in an emergency situation.
Absolutely, you're spot on. It's like trying to solve a puzzle, but you're missing half the pieces. Older adults, they often have underlying conditions like diabetes, high blood pressure, you name it, and they might be on multiple medications, all of that. It can really complicate trauma care.
Yeah, because something that seems completely unrelated.
It can totally change the game.
They gave an example in here. An older adult, they fall, seems okay at first, but they're on blood thinners. I have to admit, before reading this, I don't think I would have thought that was such a big deal.
Right, and that's exactly why we need to be talking about this.
Yeah.
Because those seemingly minor details, they can be absolutely crucial in geriatric trauma.
So blood thinners, break it down for us. What's a key thing people should understand?
So blood thinners, they're medications that help prevent blood clots, which is important for certain conditions. But in a trauma situation, they can make bleeding much harder to control. What might have been a minor bump for someone else could turn into serious internal bleeding for someone on blood centers.
It's like that saying, what you don't know can hurt you, or in this case, what you don't tell the doctor.
Exactly. Communication is key here. It's absolutely vital to tell medical professionals about any medications an older adult is taking. Even vitamins, supplements, it all matters.
Because it might seem completely unrelated to the injury.
Right, but it could change the entire approach to treatment. We need the full picture.
It's like we need this deeper understanding of how aging changes things just to even know the right questions to ask, you know, what to be extra careful about.
It really changes your whole perspective. And the thing is, it's not just about treating the immediate injury, it's about knowing what complications are more likely in older adults and being prepared for that.
Which brings us to specific injuries and why they can play out so differently. Like the document mentioned head trauma. That seems like a big one.
Oh, absolutely. And one thing that's really important to understand with head trauma and older adults is that as we age, our brains actually shrink a little bit.
Wait, really? Our brains shrink?
They do. It's a normal part of aging, but it can have serious consequences when it comes to head injuries.
Okay, I'm listening. This is fascinating, but a little creepy.
Right. So because the brain shrinks, it creates more space within the skull.
Okay.
And that extra space, well, it means there's more room for blood to accumulate if there's bleeding in the brain.
Ah, so even what looks like a mild bump on the head.
Could actually mean there's a more significant bleed happening internally.
And it's not as obvious as with younger people.
Exactly. Older adults often don't show those classic symptoms of a brain bleed as quickly. They might seem okay at first, but then hours or even days later, start experiencing confusion, drowsiness, headaches. It can be very subtle.
Okay, so bottom line, if someone older takes a hit to the head, no matter how minor it seems,
Err on the side of caution. Always get it checked out.
this is really making me rethink a lot of things. Like I never would have thought about how something as, I don't know, every day as a fall could be so much more complicated for older adults.
Oh, absolutely. And it's not just falls. The document also talked about something I found really interesting, the increased risk of complications from chest trauma in older adults.
Chest trauma. I mean, that sounds serious to begin with. What makes it different for, someone older?
Well, think about it this way. A chest injury, it's not just the impact itself, it's how that impacts breathing. And older adults, they often have decreased lung capacity. Their respiratory muscles might be weaker.
Right, so just taking a deep breath.
Becomes a whole lot harder. So something like a rib fracture, which might be painful, but not life-threatening in a younger person, it can significantly impair their ability to take those deep breaths, to cough effectively.
And that makes them more susceptible to things like pneumonia, especially if they're dealing with other health issues already.
Exactly. It's like this domino effect. And that's what makes geriatric trauma so complex. You can't just look at the injury in isolation. You have to understand how aging affects all of the body's systems and how those systems interact.
It's like what seems like a minor injury in one person can cascade into something much more serious in another, just because of their age.
You got it.
So it sounds like what we really need is to almost shift our whole way of thinking about this, to see geriatric trauma as its own specialized field.
I think you're exactly right. And the good news is that is starting to happen. A lot of hospitals now are implementing geriatric trauma programs with specialized protocols, care teams that are specifically trained to deal with the unique needs of older patients.
So recognizing that, hey, these aren't just, regular injuries, they require a different approach.
Exactly. It's about recognizing the unique vulnerabilities that come with aging and tailoring treatment plans accordingly. Like, for example, did you know there's something called the Frail scale? It's specifically designed to assess frailty in older adults. The Frail scale? No. What's that?
So FRAIL, it's actually an acronym.
Okay.
It stands for fatigue, resistance, ambulation, illness, and loss of weight. And healthcare providers use this scale to kind of get a sense of an older adult's overall health and resilience. Are they showing signs of frailty?
And how does it work?
They basically score each of those items on the scale, and the higher the score, the more frail the individual. It helps paint a more complete picture.
So if someone scores high on this Frail scale, does that change how doctors approach their treatment, especially after an injury?
Big time. It's a huge red flag. Means there's a higher risk of complications. Recovery might be tougher. They might need a longer hospital stay. Maybe they need specialized rehab or extra support at home just to make sure things go smoothly.
It's like you were saying before, looking past the obvious injury to see the whole picture. Exactly. And that actually brings up something else really important from this document. We're going to be thinking about what happens after the emergency room too.
Oh, right. So we've dealt with the immediate injury, stabilized them. What then? What'd they say was important in that post-emergency phase?
They made this really good point. Recovery for older adults. It's not just about the physical healing, though of course that's huge. It's about getting back their independence, their quality of life. And that can be a much longer, more complicated process than we might assume.
I imagine that's different for everyone, right? Depending on their health overall, where they live, what kind of injury it was.
You got it. That's why this source talked about functional assessments, figuring out what was this person's baseline before the injury. Were they living on their own? Any trouble getting around or with memory? That info's key to making a rehab plan that actually works for them.
So it's not just, okay, get back on your feet. It's get back to your life.
Exactly. And that might take a whole team, doctors, nurses, physical therapists, occupational therapists, even social workers, everybody pitching in to make sure that person has the best shot at getting back their independence.
Man, this has been eye-opening. We started with a few jokes about senior moments, and now we're talking about physiological reserves, the Farrell scale, needing a whole team for recovery. Makes you think twice about what we often brush off as just accidents, huh?
It really does.
Yeah.
And to me, that is the biggest takeaway from all of this. We got to shift our perspective. Instead of just seeing an accident, we need to see that individual, see how all these factors play together and how that can make older adults so much more vulnerable.
And with that understanding, it's like we have a responsibility now, right? It's not enough to just react after someone gets hurt. We've got to be proactive, trying to prevent these situations, making sure people get the best possible care.
Couldn't agree more. This knowledge, it empowers us to be better caregivers, whether it's our own parents, grandparents, or even just someone we encounter who might need a little extra help.
So as we wrap up here, what's the one thing you really want our listener to walk away with from this deep dive on geriatric trauma?
I'd say it's simple, but crucial. Awareness is everything. The more we understand about the challenges, the vulnerabilities that come with aging, the better we can make things. So older adults get the specialized care they deserve, and they can live those healthier, safer, fuller lives.
Beautifully put. Big thanks to you for taking this deep dive with me. It really got me thinking.
Happy to be here. Always enjoy these conversations.
All right, so you're about to start your AR rotation, huh? Want to make sure you're totally on your game when those little ones come through the door? Well, you've come to the right place. We're tackling pediatric trauma in this deep dive, and let me tell you, we've got an expert here who knows how to make this stuff stick. We're talking bridging that gap between textbook knowledge and, the real deal when things get intense.
You bet. Pediatric trauma, it's a whole other world.
Totally. And the research we dug into for this keeps driving home this point. Kids are not just small adults, which, yeah, okay, we hear that all the time, but what makes that difference so crucial when we're talking trauma?
Think about it this way. Treating a child for trauma, it's almost like you're dealing with a totally different species. Seriously, their anatomy, their physiology, it's all a moving target, right? And that changes everything. Take their head to body ratio, for instance.
Oh, right. Their heads are way bigger proportionally compared to us grown-up folks.
Exactly. And that makes them so much more vulnerable to head injuries. Even from pulse head for an adult, no big deal. Plus, their skulls are still fusing, so the way that force impacts them, totally different.
So a little tumble for them could be
a really big deal.
Yeah, more serious than we'd think.
And the anatomical differences don't stop there. Their bones are still growing like crazy too. Way more pliable than adult bones.
Which is why we see things like green stick fractures more often. Right?
Yeah, exactly. That bending and cracking, but not like a clean break.
Right. Bend and snap, not a full-on snap.
But here's the thing. Managing those fractures, especially near growth plates, whole different ballgame.
Yeah.
You've got to prevent long-term growth problems. It's not just about putting the bone back together. It's about working with a structure that's, still under construction.
Wow. It's like you're trying to fix it while it's still busy building itself.
Exactly.
What about those physiological differences? I know the research mentions stuff about metabolism and body surface area playing a role too.
Huge factors. Kids, they've got these supercharged metabolisms, helps them heal faster, which is great. But flip side, they lose heat so much quicker than adults. All that surface area.
So keeping them warm during a trauma, that's
absolutely crucial.
Not just let's make them comfy.
No, it's critical for their whole system staying stable. Same with fluids. Totally different needs.
It's wild how these tiny differences can make such a huge difference in how we approach their care. So we've covered the basics, like why kids aren't just tiny adults when it comes to trauma. But the research, it goes deeper, right? How these differences actually play out at different ages, and that's where things get really interesting.
It's wild, right? Like a traumatic event that might leave an adult with a few scrapes could be devastating for a child. And what kind of injuries we're dealing with changes so much as they grow.
Yeah, the research kept highlighting infants, like how incredibly vulnerable they are. What makes them like a unique category?
Well, they're still developing so rapidly, right? Their bodies are just so delicate, especially their heads.
Makes sense.
That big head-to-body ratio, like we talked about, huge factor here. Plus, their skulls are thinner, more pliable.
More vulnerable to everything.
Exactly. Fractures, bleeding inside the skull. So even what seems like a minor bump could be a huge deal.
So if we're examining an infant after a trauma, what should we really be paying attention to?
One of the biggest things, bulging fontanelle.
Right, that soft spot.
Totally normal part of their development, but in a trauma situation.
Yeah.
Could be a sign of dangerous pressure building up in the skull.
Oh, wow. Okay, so that's one to watch for sure. The research also mentions something called the Pediatric Glasgow Coma Scale. Is that basically a different way of checking how responsive they are, like their level of consciousness?
Exactly. You can't use the adult one on an infant, right? They can't exactly tell you what hurts or follow commands. So the pediatric version, it's all about assessing them based on their developmental stage.
Right, because what's normal for a 6-month-old versus a 2-year-old, totally different.
For sure. So we're looking at things like eye movements, how they respond to sounds, even how they move their limbs, all age appropriate.
So we're adapting our whole approach, basically.
Exactly. And then you've got toddlers.
Oh boy, toddlers. Whole different ball game, right? They're like little explorers, but always leading with their
Heads, yeah, in their mouths.
Oh, right, putting everything in their mouths.
Airway foreign bodies, that's huge with toddlers.
And their airways are just so tiny.
Exactly. Even a small object can cause a big obstruction.
It's amazing the things they'll try to, like, swallow.
Tell me about it. We see it all in the ER. Small toys, coins, food. You wouldn't believe it.
What makes it even trickier is that it's not always, like, super obvious, right?
Right. You might not immediately think, oh, it's a foreign body.
Yeah.
They might just have a cough or seem like they're having a hard time breathing.
So we got to be extra careful.
Definitely. And then there's teenagers.
Right, teenagers. Getting closer to that adult stage, but still so much development happening.
And they start to mirror adult injury patterns more.
Like we see more sports injuries, things like that.
Exactly. Car accidents, unfortunately, intentional injuries.
Oh, right, like self-harm or
Yeah.
heavy stuff. But their bodies are tougher, right?
They tend to be, yeah. More resilient than those younger kids.
Right.
But the emotional and social impact of these injuries, that can be huge at that age.
So important to remember that it's not just the physical stuff, it's everything.
It's amazing how much a difference a few years makes when we're talking about kids and trauma, huh? Each age, it's like its own little puzzle. But speaking of puzzles, the research mentioned some pretty specific tools and techniques they use in pediatric trauma. What were like the essentials? If you're heading into an ER rotation, what do you really need to know?
Oh, there are definitely some specialized tools of the trade, you could say. And one you will become very familiar with is the Broslow tape. It's like your cheat sheet for pediatric trauma.
Cheat sheet? Okay, I'm listening. Tell me more.
So it's this tape, right? Blight colors, like a giant ruler almost. And we use it to estimate a child's weight based on their height.
So you just like hold it up next to them. Pretty much. Find their height on the tape, and boom, that section tells you everything. What size equipment to use, what dosage of meds, even how much to inflate the blood pressure cuff.
Wow, that's incredible. It takes out the guesswork.
Exactly. And in pediatric emergencies, every second counts. So the Broslow tape, make sure we're giving the right treatment right away, and it's all tailored to that specific child's size.
That's really cool. The research also mentioned the pediatric trauma score. What is that exactly?
Think of it like a triage system, but specifically for trauma. It helps us figure out really quickly how serious a child's injuries are.
So we know who needs to be seen, like right this second.
Exactly. We factor in things like their airway. Are they breathing okay? What's their blood pressure like? How alert are they? Even their age gets factored in. And based on all that, we give them a score. Lower the score. More critical the situation.
So it's all about prioritizing.
Exactly. Now imagine this. You've got a child who's critically injured, but you're having trouble getting an IV line in. Their veins are tiny, they're scared, maybe even in shock. That's where IO access comes in.
IO meaning going into the bone.
Yep, directly into the bone marrow.
That sounds intense.
It can seem that way, but it's actually very safe and effective. Done correctly, of course. And when you need to get fluids and meds into a child quickly, nothing beats it.
Wow. So in those really critical situations,
It can be a lifesaver.
yeah,
Literally. And that's what it's all about, right? These tools, these techniques, it's about giving these kids the best possible chance, especially in those first few minutes after a trauma.
absolutely. And speaking of making a difference, the research touched on a tough topic, but so important: non-accidental trauma. And this is where our job goes way beyond just like fixing broken bones, right?
You got it.
Yeah.
Non-accidental trauma, child abuse, basically. It's a reality, and we should be ready to recognize it and intervene.
So what are some of those like red flags, the things that would make you suspect abuse might be going on?
Sometimes it's a gut feeling, like the story just doesn't line up with the injuries, or the child is acting really withdrawn, really scared. Other times it's more concrete, like they have fractures that are healing, but at different stages, which tells you those injuries happen at different times. Or burns, but they have a really unusual pattern. Bruises in places you wouldn't expect from a typical fall.
So it's about like really observing, noticing those little inconsistencies.
It's trusting your gut. If something feels off, it probably is.
And then what? What do you do if you suspect abuse?
We have a responsibility to report it, right?
Yeah.
Legally, ethically, we have to. Child Protective Services, law enforcement, whoever we need to make sure that child is safe.
It's a heavy responsibility, but ultimately...
It's about protecting those who can't protect themselves.
Yeah.
Absolutely.
Okay, so we've talked about the initial response, but what about the long game? The research talked about long-term effects of pediatric trauma, too. It's not just about getting them patched up and out the door, right?
Not at all. We have to think about the physical complications, for sure. Like if there was a fracture near a growth plate, that could cause problems down the road, but also the psychological and emotional trauma.
Yeah.
That can have a huge impact on their life and their family's life.
So follow-up care is so important.
It's crucial. And it can involve so many different things. Physical therapy, maybe occupational therapy, counseling, definitely. It's about treating the whole child, not just the injury.
This has been such an incredible deep dive. You've given us so much to think about. Any last words of advice for our listeners out there as they get ready to start their ER rotations, work with these little humans?
You've chosen an amazing but tough field. It's challenging, rewarding. Remember to trust your gut, lean on your team. You don't have to know everything. Ask for help. And never, ever forget how much of an impact you can have. You, just one person, can make all the difference in a child's life.
I love that. And to our listeners, good luck out there. You've got this. Every experience, even the tough ones, you're learning. And we'll be here, ready for the next deep dive. Until next time. All right, so picture this. You roll up on a trauma scene. Sirens are blaring. You're ready for anything, the drill. But then you realize your patient is pregnant.
Yeah, it definitely changes the game when pregnancies involve all those trauma assessments. We know all the protocols, everything's still applicable, but there's a twist.
Right, because now we're not just treating one patient, are we?
Exactly. Now you've got two patients, each with their own very specific needs.
And that's what this deep dive is all about. We're really digging into trauma in pregnancy and intimate partner violence today. And I gotta say, some of this stuff was pretty eye-opening.
It really makes you think about all the ways pregnancy just throws a wrench into our usual assumptions about trauma. Like take blood loss, for example.
Okay, yeah, because a pregnant woman isn't dealing with the same blood volume as the rest of us, is she?
Not at all. By the third trimester, her blood volume could have increased by almost 50%. That's a lot of extra fluid in there.
Wow. So she could be bleeding externally what looks like a normal amount to us, but internally it's a whole different story.
Exactly. And that's just one example of why assessing and treating have to happen almost simultaneously for both mom and baby. It's a delicate dance.
Like juggling two emergencies at once. You're managing mom's injuries, but you also have to make sure baby's okay. Speaking of which, this guide talks about something called supine hypotensive syndrome. What is that exactly?
Okay, so imagine this typical trauma patient on their back standard position, right? But after 20 weeks of pregnancy, that's a big no-no.
Really? Why is that?
Because the weight of the uterus can actually compress a major vein that carries blood back to the heart, and that's what causes supine hypotensive syndrome.
So we always go with the left lateral tilt after 20 weeks. No exception.
You got it. Even if you have to get creative to keep her stable and tilted, it's vital. You're securing two lives with that simple adjustment.
That's incredible. See, this is why I love these deep dives. You never know what little detail can make a huge difference out there. Okay, let's switch gears a bit. Let's say we get a call about a pregnant woman involved in a car accident. What are we thinking about with blunt force trauma in these situations?
Well, the thing about blunt force trauma and pregnancy is that even impacts that seem minor can have major consequences.
Because we can't always see the damage, right?
Exactly. One of the biggest concerns is placental abruption.
And just so we're all on the same page, can you break down exactly what that is?
Sure, placental abruption basically means the placenta is detaching from the uterine wall, which can be partial or complete. And that's a huge problem because it can cut off the flow of oxygen and nutrients to the baby, not to mention lead to severe bleeding in the mother.
So even if there are no visible injuries, this placental abruption could be happening internally.
Exactly. That's why a thorough assessment is crucial, even if mom seems okay at first glance.
So we're talking close monitoring, fetal heart rate checks, the whole 9 yards?
Absolutely. You got to be extra vigilant looking for
Yep.
any signs of trouble. Now, let's say this same patient also experienced some penetrating trauma during the accident.
Oh, wow. Okay, so now we're talking about a whole other level of complexity.
It definitely adds another layer. What's interesting is that in early pregnancy, the uterus can actually act as a shield, protecting the fetus from penetrating trauma.
Oh, really? I would have thought it would be the opposite.
It makes sense when you think about it, but as the pregnancy progresses and that uterus gets bigger, it becomes much more vulnerable.
So the location of a penetrating injury becomes even more critical as the pregnancy goes on.
Exactly.
Yeah.
You've got to consider the position of the baby as well as the mother's organs.
And of course, we can't forget about falls.
Right. They might not seem as dramatic as, say, a car crash,
Yeah.
but falls are actually one of the most common causes of trauma in pregnancy.
Which makes sense when you think about it. Your center of gravity changes. You're not as steady on your feet, and you might not react as quickly if you trip.
Exactly. And just like with blunt force trauma, even what seems like a minor fall can lead to those serious complications.
Placental abruption, all that.
Exactly. So we always have to err on the side of caution.
Thorough assessments are key no matter what. So we've covered a lot of physical trauma scenarios, but this guy also goes into something that's really important, but not always easy to talk about: intimate partner violence, or IPV.
Right. And it's something that we as first responders, unfortunately, we need to be prepared to address.
Absolutely. Because trauma in pregnancy isn't always accidental, is it?
Sadly, it's not. And for many women, the most dangerous place isn't out on the street, it's in their own home.
That's a tough reality. So how do we as first responders get better at recognizing those signs of IPV, especially in a situation that's already so high stress?
Well, one of the most important things is routine screening.
Okay.
This guide really emphasizes that asking every pregnant patient about potential abuse, even if there are no obvious signs.
Makes sense.
You'd be surprised how many cases go undetected without that proactive approach.
It's about creating that safe space for them to open up, right? Even if they might not volunteer that information at first.
Exactly. And it's also about knowing what to look for.
Because it's not always going to be a black eye or a broken arm, right?
Right. It's not always obvious.
Yeah.
Beyond the physical signs like bruising on the face, neck, or abdomen, you also have to be aware of behavioral cues.
So what kind of behaviors are we talking about? What should we be looking for?
It could be anything from seeming anxious or withdrawn to being overly cautious around their partner. You know, maybe they hesitate to answer questions or defer to their partner for the answers.
So those subtle things can actually tell us just as much as a physical injury.
Absolutely.
We really need to trust our gut on that one. If something feels off, it probably is.
I totally agree. Even a hunch that something's not quite right warrants further investigation. And this guide actually gives some really clear steps on how to navigate that whole process.
Okay, so let's say we're in that situation. Our gut is telling us something's wrong. What do we do? What concrete steps can we take to address potential ITV?
First and foremost, documentation is key. Every single detail matters.
Yes, I imagine that's even more important in these cases.
It really is. We're talking about the patient's account of what happened, descriptions of any injuries, photographs if possible, and with consent, of course. All of that can be incredibly valuable later on, both medically and legally.
And obviously the patient's immediate safety is the priority. But what about the long term? Where do we even begin to connect these women with the resources they need to break free from that cycle of violence?
That's where this guide really shines. It lists local shelters, support groups, legal aid organizations. It's a whole network of support that a lot of these women don't even know exists.
So it's about being that bridge for them, right?
Exactly.
Yeah.
Our job is to bridge that gap and empower them with options.
Because you're right, they might not be ready to leave that situation.
Right.
But just knowing there are people out there who understand and want to help, that can make a world of difference.
Exactly.
Yeah.
And that's where that trauma-informed approach is so important. Approaching these conversations with empathy, without judgment, that can be incredibly powerful.
It's about giving them the power to make their own choices, even if it's tough.
Exactly. We offer support, we offer options, but ultimately it's their decision.
And sometimes that's all it takes, just having that support, knowing you're not alone. But this guide also mentions the legal side of things, which can be tricky. There's talk about mandatory reporting. What's the deal with that?
Right. Well, that's a huge part of our job as first responders. We have a legal and ethical obligation to report suspected abuse, especially when children are involved.
Of course.
The specific rules might vary depending on where you are, but it's crucial to know what those are.
So it's about finding that balance, right?
Exactly.
Between doing what we have to do legally and still maintaining that trust with the patient.
Absolutely.
Yeah.
We never want a victim of IPV to hesitate to call for help because they're afraid of what might happen.
Right. That would be the worst case scenario.
Exactly.
Yeah.
It's definitely a delicate situation.
Yeah.
But that's why training and resources like this guide are so important.
It's not just about knowing the protocols by heart. It's about understanding, the weight of these situations and responding with both expertise and empathy.
Couldn't have said it better myself.
It's a lot, but that's what makes our work so vital.
Well said. This deep dive has really highlighted the unique challenges and responsibilities we face as first responders, especially when we're dealing with trauma in pregnancy.
Absolutely. We've covered so much ground, from those physiological changes to the hidden dangers of IPV to the balance of providing compassionate care while navigating all the legal stuff.
And remember, this is just the start. This deep dive has given you some essential knowledge, but the learning never stops.
It never does.
Take this information back to your team, share it with your colleagues, and keep the conversation going.
Because ultimately, we're all in this together. We have a responsibility to be there for the most vulnerable, to be a voice for those who might not have one. So as we wrap up this deep dive, we'll leave you with this. What more can we do both individually and as a system to shift from just reacting to trauma and IPV to actively preventing it? It's a question worth thinking about, and one that needs our attention and action. Thanks for joining us on this crucial deep dive. Stay safe out there and keep making a difference.
Ever feel like, in medicine, some situations need a serious playbook? Like, what happens when someone needs care that's, beyond your average ER?
Beyond the typical hospital, for sure.
Exactly. That's where transfer to definitive care comes in today's deep dive topic.
And it is a deep one. Think less of a quick ambulance ride and more like a high-stakes handoff in a race against time. We're talking about getting a patient to the exact right specialist, often in a really critical window.
You requested this deep dive because you're clearly curious about those inner workings, and trust me, we've got some fascinating insights from recent research. It's way more intricate than I'd ever imagined. Like, for starters, why does a transfer even become necessary? It's not just about bumping someone up to a fancier hospital, right?
Right. It's definitely more nuanced than that. We're talking about those serious situations, someone with severe trauma, multiple injuries where different specialists need to be involved, or cases that just require, care beyond a hospital's usual capacity.
Makes sense. So it's about having the right resources for a complex problem.
Exactly. I can give you an example that always stuck with me. I once treated a patient with a really complex pelvic fracture after a car accident. His local hospital was great, don't get me wrong, but they simply didn't have the surgical expertise this guy needed. And that's when transferring to a level 1 trauma center became absolutely critical.
Okay, so level 1, that implies there are different levels of trauma centers. What makes them different?
You're catching on. It's essentially a ranking system based on available resources and specialist availability. Level 1 is the highest, meaning it's equipped to handle, pretty much any critical situation 24/7. Think dedicated surgical teams, advanced imaging the works. So for my patient with the pelvic fracture, getting him to a level 1 center meant immediate access to the best possible care for his injuries.
That makes total sense. Mashing the patient's needs with the right level of resources. Our research outlines this whole transfer process, and honestly, it's like a carefully choreographed dance, but with, life or death stakes.
It absolutely is. And it all starts with stabilizing the patient before they're even moved. We call it the ABCDE approach: airway, breathing, circulation, disability, exposure. It's about ensuring the patient is as stable as possible before they're even loaded into an ambulance.
So it's about more than just, say, stopping the bleeding. It's about prepping the patient for the journey ahead.
Exactly. A strong foundation is crucial for what comes next. You're exactly right. Strong foundation, that's key. And speaking of what comes next, once they've stabilized the patient and chosen the right facility, it's time for the transport itself.
The actual journey.
Right, the journey. And you might think it's as simple as, throwing them in an ambulance and hitting the gas.
Like in the movies.
Yeah, not quite. It's a whole lot more nuanced than Hollywood makes it seem.
Okay, so spill the tea. What are some factors that actually come into play when deciding how to move someone? Is it always an ambulance?
Not always. Distance is a big one. Then there's the patient's condition, of course. And believe it or not, even the weather can be a factor.
Wow, so many moving parts.
For sure. I've seen situations where a helicopter was the only option, especially in, say, rural areas or after a major highway accident, something like that. Because, I mean, time is of the essence in so many of these cases, especially time-sensitive conditions like strokes or heart attacks.
Right. Every second counts. That actually reminds me of this documentary I saw about air ambulances. Talk about high-pressure situations. And it really made me realize just how much goes on behind the scenes during these transfers. It's more than just the ride itself.
You're hitting on a crucial point. Communication, for example, is absolutely paramount throughout this whole process. Think of it like a relay race, where the baton is critical patient information.
Oh, I like that analogy.
The sending hospital has to give the receiving team a detailed report about everything, the patient's condition, treatment given, ongoing needs, so there's no break in care during that transfer.
It's like that moment in a cooking show where one chef hands their dish off to another to finish it up, right? You really don't want anything to go wrong at the last minute.
Perfect analogy, and it doesn't stop there. Throughout the journey, there's constant monitoring going on, vital signs, pain management, even something as simple as making sure the patient stays warm enough. Remember, we're often dealing with a moving vehicle here.
Right. It's not exactly like being cared for in a stable hospital bed. I never even considered the bumps, the turns, all while managing, a serious medical condition.
Exactly, and that's why specialized training is so critical in this field. You need to be able to anticipate potential complications in that kind of environment, manage all the medical equipment, and be prepared to act quickly, all in a moving vehicle.
Wow. It's like those mobile hospitals you see in disaster movies, but this is everyday life for you guys. So we've got stabilization, transport, constant communication. It's so much more involved than most people realize. And our research also mentioned these things called specialized transfers, which sounds even more, intense.
Oh, it definitely can be. Just imagine transferring a premature baby, for example. They require such specialized neonatal care, specialized equipment, and it's this incredibly delicate dance to keep them stable during a transfer.
I can only imagine. It just blows my mind, the level of care and precision needed in those situations.
It's truly remarkable.
And it's not just babies, right? Our source mentioned pregnant trauma patients. That's a whole other,
A whole other ballgame. You're essentially dealing with two patients in one. You have to think about the mother's injuries, of course, but also the well-being of that unborn child. It requires serious coordination between trauma specialists, obstetricians, sometimes even neonatologists, a true team effort.
Wow. It really highlights how every single transfer is unique, with its own set of, challenges. And then you have those situations you just, hope you never have to face, like a mass casualty incident.
Those are the ones that really test the system. Suddenly you're dealing with this huge influx of patients who need to be assessed, triaged, and potentially transferred to different facilities with the capacity and specialties to treat them.
Oh man, it's like that classic scene in every medical drama where the ER doors burst open and everyone jumps into action.
Right, except in real life, it's less about the drama and more about carefully orchestrated chaos, You need those clear protocols in place. Effective communication is paramount, and the ability to adapt quickly to these evolving situations, that's key.
So even after that ambulance arrives at the receiving hospital, the work still isn't over.
No, not at all. The receiving team needs to be ready to, as they say, hit the ground running. That handoff is critical, like passing, we'll stick with that baton analogy, a very fragile baton.
Okay, I'm loving that analogy, the pressure to not drop the baton. Right. So what actually happens in that final handoff to ensure a smooth transition?
It boils down to clear, concise communication, a comprehensive report from the previous team, a verbal update on the patient's current status, and making sure there's a shared understanding of that ongoing care plan. Those are all absolutely crucial.
It's amazing to see just how much emphasis is placed on communication during this whole process. It really is like the glue that holds everything together.
100%. Without effective communication, even the most carefully planned transfer can go sideways, We rely on each other, paramedics, nurses, physicians, to share information seamlessly. That's what ensures the best possible outcome for the patient.
This deep dive is really opening my eyes to the intricate web of care that surrounds a patient during a transfer. It's like this hidden world most people never see.
And a critical one.
Absolutely. It's incredible to think about the future of something so critical, yet, like you said, often unseen. We've learned so much about how transfer to definitive care works right now, but it seems like this whole system is always adapting, always improving.
Exactly. That constant evolution is what makes this field so fascinating, honestly. We're always striving for those better, faster, safer ways to get patients the specialized care they need, precisely when and where they need it most.
This whole deep dive has really highlighted how it's such a team effort, like a carefully coordinated relay race, from the moment someone needs that higher level of care all the way to the finish line.
Couldn't have put it better myself. And like any winning relay team, communication is absolutely key. That's one area in particular where I see even more potential for improvement down the line.
Oh, interesting. Like what?
Well, imagine if we could streamline communication even further. Like, what if we had universal electronic medical records that everyone could access? Or even AI-assisted handoffs to make sure nothing gets missed?
Wow, AI stepping in to make sure that critical information doesn't get lost in translation. That's kind of mind-blowing.
It really is incredible. And who knows what other technological advancements are just around the corner. We're already seeing drones being used for medical deliveries in some areas. Maybe someday they'll even play a role in actually transporting patients, especially in those really hard-to-reach locations.
Drones as ambulances. Now that's a future I'd like to see. It's exciting to think about the possibilities. This deep dive has been a wild ride, from understanding those different levels of trauma centers to imagining a future with drone ambulances.
It just goes to show how complex and constantly evolving the world of transfer to definitive care really is. It's more than just an ambulance ride. It's a complex, interconnected system designed to get patients the right care at the right time, no matter the obstacles.
Absolutely. A huge thank you to you for guiding us through this fascinating and intricate world.
Happy to be here. It's a topic I'm passionate about, for sure.
We can tell.
Oh.
And to our listener, we hope this deep dive has given you a newfound appreciation for the incredible, often unseen work that goes into ensuring patients get the definitive care they need every step of the way.
Hey there! Today we're diving deep into Trauma Essentials, a rapid review guide.
Designed to get you ready to ace the ATLS.
From what I understand.
This exam is no joke.
So we're going to break down the book's most important points.
Those high-yield concepts.
That will boost your confidence on exam day.
We're talking about going beyond just memorizing facts and figures.
We want you to truly understand the why behind the what.
So you can apply those principles in real-life trauma situations.
And we've got excerpts from the book itself.
The preface, conclusion, even the marketing materials.
Yeah.
A detailed outline of each chapter.
It's like having X-ray vision into Dr. Ahmed's approach to trauma care.
Speaking of Dr. Ahmed, his preface and conclusion highlight something crucial.
This book is all about equipping you with the tools
To respond swiftly and effectively.
in those high-pressure trauma situations.
Where every second counts.
He even uses the phrase,
The ability to respond swiftly can mean the difference between life and death.
talk about high stakes.
And that's precisely what the ATLS is designed to test.
Your ability to make the right calls under pressure.
Absolutely.
Yeah.
And judging by the chapter outlines,
The book's structure seems to align perfectly with the exam's demands.
it breaks down trauma care into those digestible, manageable chunks
From the initial assessment
to managing specific injuries.
to special populations.
Speaking of initial assessment, Chapter 1 jumps right into it
It reminds us that every second counts.
and emphasizes that systematic approach. The primary survey,
ABCDE.
airway, breathing, circulation, disability exposure.
Dr. Ahmed really drills home that this is the foundation of trauma care.
Regardless of the specific injury.
It's like a mantra in emergency medicine.
For a reason.
Those 5 letters can be the difference between a life saved and a life lost.
And it's not a one-time checklist either.
You have to continuously reevaluate.
Especially as things can change rapidly in trauma situations.
Exactly, and amidst all the chaos.
You can't forget to gather that essential patient history.
That's where AMPLE comes in.
Allergies, medications, past history, last meal, and events leading up to the injury.
It seems so simple, right?
But I can imagine how, in the heat of the moment, those details could easily slip your mind.
Forgetting to ask about a penicillin allergy, for example.
Could have disastrous consequences.
Absolutely. And Dr. Ahmed doesn't shy away from those special considerations.
Right off the bat, he dives into the unique challenges of managing trauma in pediatric, geriatric, and pregnant patients.
And rightfully so.
They're not just smaller versions of adults.
Their bodies respond to trauma in vastly different ways.
He makes a great point about this in the preface.
Their anatomy, physiology, even their responses to treatment can vary significantly.
Recognizing those nuances is absolutely key to providing appropriate, effective care.
Now let's talk about Chapter 2.
Airway and ventilatory management.
Things get real very quickly here, wouldn't you say?
Absolutely. A clear airway is non-negotiable in trauma care.
Obstruction can lead to brain damage in minutes.
And death soon after.
Dr. Ahmed dives right into those life-saving techniques,
Like the jaw thrust maneuver.
which is all about protecting the cervical spine while establishing an airway.
And let's not forget about intubation.
That's where things get really intense.
Knowing when to intubate, how to do it safely.
Especially in a trauma setting where time is of the essence.
That's some high-level skill right there.
He brings up rapid sequence intubation,
RSI
which, from what I understand,
is a specific procedure for quickly securing an airway in critical situations
it often involves sedating and paralyzing the patient.
to ensure a smooth and rapid intubation process.
You're exactly right.
It's about speed and precision, especially when dealing with a compromised airway.
And speaking of specialized situations,
Dr. Ahmed really emphasizes the unique considerations for managing the pediatric airway.
as he points out in the chapter outline, a child's airway is anatomically different.
Smaller and more prone to obstruction.
The margin for error is significantly smaller.
So having a deep understanding of those anatomical differences is critical.
Now, brace yourself.
Chapter 3 is all about shock.
This is where things get really interesting, wouldn't you say?
Absolutely. Shock is the body's response to a critical situation
Like significant blood loss.
or a severe allergic reaction.
Dr. Ahmed stresses that recognizing the different types of shock is crucial.
As misidentifying it can have devastating consequences.
He's not messing
He
around.
jumps right into the 4 main types.
Hypovolemic, cardiogenic, distributive, and obstructive.
And from what I gather,
The ATLS really tests your ability to differentiate between them.
you're spot on.
Each type of shock has its own unique set of causes, symptoms, and treatment approaches,
He dives into fluid resuscitation as a cornerstone of managing shock.
even mentioning the Parkland formula.
Yes, the Parkland formula.
That's the go-to calculation for estimating fluid replacement in burn patients,
It's all about preventing hypovolemic shock.
which is essentially shock caused by severe fluid loss.
And then he brings up a fascinating concept.
Damage control resuscitation.
It sounds like a bare minimum, stabilize now, fix later approach.
Prioritizing immediate life-saving actions over extensive repairs that can wait.
That's an excellent way to put it.
It's a shift in thinking.
Focusing on what absolutely needs to be done in those first critical moments.
To prevent further damage and give the patient the best chance of survival. Now moving on to Chapter 4.
We're diving into the chest cavity with thoracic trauma.
This is where things can unravel exceptionally quickly.
Absolutely.
We're talking about life-threatening situations like a collapsed lung.
Or even a ruptured aorta.
Dr. Ahmed clearly emphasizes that time is critical here.
One condition that really jumped out at me was tension pneumothorax,
Imagine air trapped in the pleural space.
compressing the lung and even pushing on the heart.
It sounds terrifying.
It can be rapidly fatal if not recognized and treated immediately.
Dr. Ahmed emphasizes recognizing those classic signs
Tracheal deviation, absent breath sounds.
and distended neck veins.
It's all about quick, decisive action.
And for those situations,
Chest tubes become absolutely vital.
they are true lifesavers in these cases,
Chest tubes allow you to drain blood or air from the pleural space
giving that lung room to re-expand.
and restoring normal breathing,
It makes sense that Dr. Ahmed would highlight them.
as there's such a fundamental skill in trauma care,
He also delves into massive hemothorax,
which, as the name suggests,
involves a significant amount of blood accumulating around the lungs.
this can be particularly dangerous due to blood loss and impaired breathing,
Then there's aortic injury.
which Dr. Ahmed refers to as a potential silent killer.
What makes this type of injury so difficult to catch?
A tear in the aorta, often caused by high-speed deceleration injuries.
Can lead to massive internal bleeding.
it might not present with obvious symptoms initially,
So maintaining a high index of suspicion,
especially after a car accident, is crucial.
that makes the content of Chapter 5, Abdominal and Pelvic Trauma, all the more critical.
This is where the potential for internal bleeding is significant.
You're right.
The ability to swiftly assess and manage bleeding from vital organs like the liver, spleen, or major blood vessels is paramount here.
And speaking of quick assessments,
The FAST exam, that rapid ultrasound,
pops up again,
Dr. Ahmed seems to emphasize this tool throughout the book.
and for good reason.
The FAST exam provides crucial information about what's happening within the abdomen.
In a fast and portable way.
It's an invaluable tool in a trauma setting.
He also delves into the complexities of pelvic fractures.
It's not just about broken bones, is it?
Not at all.
Pelvic fractures carry a significant risk of severe bleeding due to the rich blood supply in that area.
They require careful assessment and management to control bleeding and stabilize the pelvis. Moving on to Chapter 6.
We're addressing the head with head trauma.
Assessing and managing these injuries must require a deep understanding of neuroanatomy.
Absolutely.
The brain is arguably the most vital organ.
Yet also incredibly delicate.
Dr. Ahmed stresses the importance of the Glasgow Coma Scale for level of consciousness,
And of course, he covers the various types of bleeds,
such as epidural and subdural hematomas.
each having its own characteristics and treatment approaches.
It's interesting that he doesn't just focus on the immediate injury.
He also brings up long-term considerations like post-concussion syndrome,
That's an important point.
the impact of head trauma
Even seemingly mild concussions.
can have lasting effects.
It's great that Dr. Ahmed brings attention to this often overlooked aspect. Chapter 7, Spine and Spinal Cord Trauma, feels like another high-stakes area.
Where one wrong move could have devastating consequences.
Absolutely.
Immobilizing the spine is crucial from the outset.
But it's not as simple as just keeping the spine still,
Recognizing the signs of neurogenic shock.
which presents differently from hemorrhagic shock, is essential.
And then there are the complexities of managing spinal cord injuries,
The distinction between a complete and incomplete injury
with their varying degrees of motor and sensory function below the injury level.
immediately impacts treatment and potential for recovery.
Dr. Ahmed also highlights those specific syndromes,
Like anterior cord syndrome,
or Brown-Séquard syndrome.
each with its unique set of symptoms and implications.
He even covers those less common but potentially deadly complications.
Like autonomic dysreflexia.
It's a reminder that even when things seem stable, the journey to recovery in spinal cord injury is complex.
Now shifting gears to Chapter 8,
We're looking at musculoskeletal trauma.
it's more than just broken bones and ice packs, isn't it?
You could say that,
Dr. Ahmed dives into the complexities of skeletal injuries,
covering everything from recognizing different fracture types
to the potential dangers of compartment syndrome.
compartment syndrome. That sounds ominous.
It can be.
Imagine this, pressure building up inside a muscle compartment.
Usually after a fracture or crush injury,
That pressure can impede blood flow.
potentially leading to muscle damage or even tissue death if not promptly treated.
He also touches upon open fractures,
Those where the bone breaks through the skin.
significantly increasing the risk of infection.
I imagine quick action is paramount in these cases.
You're absolutely right.
Controlling bleeding, covering the wound, and administering antibiotics become immediate priorities in these situations. Moving on to Chapter 9,
We're tackling thermal injuries.
better known as burns.
They can range from minor annoyances to absolutely life-threatening situations.
You've got it.
Dr. Ahmed emphasizes the importance of assessing the burn's depth and extent,
Highlighting those quick assessment tools like the Rule of Nines.
and the Lund-Browder chart,
And, of course, the Parkland formula makes a reappearance here.
guiding fluid resuscitation efforts in burn victims to combat burn shock.
And let's not forget those less obvious but equally dangerous electrical burns.
You're right.
The damage from electrical burns extends beyond the visible surface,
Electricity can disrupt the heart's rhythm and cause extensive internal damage.
making early assessment for these complications critical. Now, Chapter 10, Pediatric Trauma.
Yeah.
It's a stark reminder that kids,
Kids are not just small adults.
right,
They have unique vulnerabilities when it comes to trauma.
they do.
Their bodies respond so differently to injury,
Yeah.
from their pliable bones
Huh?
and developing organs
Uh-huh.
to their physiological responses to shock and blood loss.
And as Dr. Ahmed points out, even seemingly minor falls, right,
Oh, absolutely.
can have significant consequences for a child
They can.
because they're still developing.
Absolutely.
For example, the fact that a child's head
Yeah,
is proportionally larger than an adult's, right?
much larger.
Making them way more susceptible to head injuries.
Absolutely. And their airways are smaller,
Right.
much more easily obstructed,
Yeah,
which adds another layer of complexity to trauma care in this population.
totally. And then,
Okay.
Dr. Ahmed also kind of bravely
Yes.
addresses the issue of child abuse in this chapter,
Right.
urging medical professionals to be vigilant in recognizing the signs, which is
yeah.
tough but important.
It's a difficult topic, but incredibly important.
Yeah.
As healthcare providers, we are often on the front lines of identifying and intervening in these heartbreaking situations.
Totally. And, he even highlights the pediatric trauma score, which
Yeah.
is specifically designed to assess the severity of injury in children.
Right.
So they have their own
They do.
scoring system,
They do.
which makes sense
As they should.
because they're not just little adults.
Exactly.
Then in chapter 11, we shift gears to geriatric trauma.
Right.
And again, it's not just about fragile bones.
No, it's not just about fragile bones.
Right. It's about the fact that
Yeah.
as we age,
Yes.
our bodies undergo.
Decades of wear and tear.
Right.
Often accompanied by multiple pre-existing conditions and medications.
Yeah.
That can really complicate trauma care.
Totally.
Yeah.
What might seem like a minor injury in a younger person
Right.
could be devastating
Could be.
in an older adult.
Absolutely.
And Dr. Ahmed really drives home that point,
Yeah,
highlighting how aging impacts every system's response to trauma,
it does.
from cardiovascular function to pulmonary
Right, yeah.
recovery.
Everything.
It affects everything.
Yes.
And he even mentions delirium as a common concern
Right.
in older trauma patients.
Absolutely.
Because it's not just about, again,
Right.
physical healing,
Right.
but we have to address the
cognitive and psychological
impacts of trauma.
impacts,
Yeah.
which can be, again, more significant in older adults.
For sure. Now, chapter 12 tackles two very sensitive and often intertwined issues: trauma in pregnancy and IPV.
Right.
And both kind of requiring a compassionate and nuanced approach,
Absolutely.
recognizing the unique vulnerabilities
Of each individual.
of the individuals involved.
Right, yeah.
And so, when it comes to pregnant trauma patients, right, it's
Yeah.
about treating two patients.
Two patients
Now,
simultaneously,
treating-
the mother and the developing baby.
Yes.
And each
It's
decision carries
so much weight.
so much weight.
Yeah.
Because it's not just one life.
Exactly.
Dr. Ahmed highlights those physiological changes of pregnancy that can really impact care.
Absolutely.
And he even mentioned something called supine hypotensive syndrome, which
Yeah.
I had never heard of before reading this. It's where the weight of the uterus compresses a major vein when the mother is lying flat on her back,
Oh, wow.
potentially leading to a dangerous drop in blood pressure,
So they can't be
not for extended periods.
on their back.
Right.
Wow.
Yeah.
And he even discusses a rather intense procedure
He does.
called a perimortem cesarean delivery,
Right.
which sounds intense.
It's a last-ditch effort
yeah.
to save mom
Wow.
and baby.
So it's really the end.
Yeah.
And then he shifts gears to IPV,
Yes.
intimate partner violence,
Which is so important.
stressing the importance of us as medical professionals,
Yes.
recognizing
Patterns.
patterns of injury that might indicate abuse.
Yes.
And this is about again, being aware of the psychological aspect of abuse and knowing the resources available
Absolutely. Having those resources available
to help these patients.
to help these patients.
escape these situations.
Yes.
Finally, in chapter 13,
Okay.
we reach transfer to definitive care.
Right.
And this is about as a medical professional, knowing when a patient's needs
Yes.
exceed.
Your facility's capabilities.
Yes.
You got it.
Right.
That's exactly right.
Not every single hospital can
Can handle everything.
handle everything.
Nope.
Right.
Right.
And so knowing when and where to transfer a patient is just as crucial
Which is crucial.
as that initial assessment and stabilization.
Absolutely.
You are
Yes.
saving a life while
Sometimes the best care you can give
right.
is knowing when to transfer that patient.
knowing your limits.
Right. To a higher level of care.
Yes, exactly. And Dr. Ahmed provides clear criteria
It does.
for transfer decisions,
Right.
emphasizing patient stability
Absolutely.
and the availability of higher levels of care.
Right.
And let's not forget about, communication
Yeah.
during the transfer process.
That handoff
Yeah.
between the transferring team and the receiving team
Right.
is absolutely crucial to make sure that patient care is seamless.
Yes. Well, what a whirlwind.
I know, right?
Tour of Trauma Essentials. This
Alright.
book
Does not shy away from the high-stakes reality.
of trauma care.
Trauma is not for the faint of heart.
It's not.
It is a very intense
Right.
area of medicine.
It's demanding.
Very demanding.
Requires quick thinking.
Quick thinking.
Yeah. And a thorough understanding of complex medical concepts.
Absolutely.
So any final advice
For our listener,
for a listener as they prepare to conquer the ATLS?
you've got to understand the why behind the what. Don't just memorize those protocols, okay? Strive to really understand the physiology, the reasoning behind those treatment algorithms. That deeper understanding will make you a more confident, more competent, and overall better trauma care provider. And of course, practice those ATLS scenarios. Get comfortable applying these concepts, in those simulated situations, and you'll be much more prepared for the real deal.
That is such good advice. And listener, while you're at it, why not see what else Dr. Ahmed has to offer? We came across his website. It's dodoctor8f.net. He might just have some extra resources there to give you that winning edge. Until next time, stay curious.
Ever find yourself wondering how trauma surgeons, how do they make those split-second decisions? Like life or death in their hands.
Yeah.
It's incredible. So we are diving into Trauma Surgery Questions and Answers
Okay.
by Dr. Atef Ahmed.
Mm-hmm.
And let me tell you, this guy, he knows his stuff.
Yeah.
Really clear explanations, even though
Yeah.
this book, get this, is from 2050.
Interesting. Yeah, it's really something how this book, it's speaking from the future, but the core stuff, the core techniques, they haven't changed that much, have they?
No, they haven't.
It's still about saving lives.
It's like he's giving us a peek into the future of trauma care.
Right.
But through today's lens. And this Q&A format, genius.
Oh, it's brilliant. It's like, when a surgeon's in a life or death situation, they don't have time to read a textbook. They need answers and fast, this format. It just clicks.
It does.
Practical and engaging. Even if you're not a doctor, you get it.
So Dr. Ahmed, he jumps right into it.
Yeah.
The ABCs.
Right.
Airway, breathing, and circulation.
Yeah.
Like we all know are ABCs.
Right.
But in trauma, that's different.
Yeah, it's not elementary stuff anymore, is it? It's a life or death, those ABCs, that's your lifeline. You stabilize them, you buy yourself time, crucial time.
And this is where this book, it sucks you in. For example, he talks about open fractures. And I'm sorry if you're squeamish.
Oh, yeah.
But we're talking bone sticking out, the works.
Yeah, you got to be ready, got to be precise. And Dr. Ahmed, he lays it all out. It's like you're right there in the OR, every step, every move.
It's incredible. He makes it, accessible, even if you're not a surgeon. Then there's this part about Beck's triad. I had to look it up.
Really?
Low blood pressure, neck veins popping,
Yes.
muffled heart sound. It's like, what? They don't sound like they go together.
But that's just it. That's how you know it's bad. Like a 3-alarm fire, those 3 things, that's cardiac tamponade. Basically fluids crushing the heart.
So the body's sending an SOS.
Yeah.
Beck's triad, it's how to hear it.
Exactly. And if, you can act. Life or death, This book, it doesn't just tell you, it tells you why. And that is gold.
It's true. It's like connecting the dots. But here's what surprised me. He goes beyond the operating room.
Oh, yeah. Trauma is way bigger than that.
Right.
The thing that blew my mind was how important a seatbelt mark can be.
Wait, so it's not just about, wearing your seatbelt.
It's a clue, right? Dr. Ahmed talks about how that mark, it could mean internal injuries, bad ones. You have to look for those things.
So it's like you see that mark, you got to think deeper.
Exactly. It's about the big picture.
Right. And speaking of big picture, he has this whole thing on the mangled extremity severity score.
Oh, yeah.
That they have to decide if
they got to amputate.
Yeah, tough call.
It's huge, right? You're not just talking about right now. You're talking about their whole life. Dr. Ahmed, he breaks down the score. Like, how bad's the injury? Is the blood flowing? How old are they? Are they healthy? Man.
Heavy stuff.
And you know what gets me? With all this intense stuff, he never forgets it's a person,
Oh, totally. Even in the preface, he talks about saving lives, that feeling, but he's honest, He talks about the pressure, the what ifs.
It's real. Even with all the technology, it's still humans in there.
Absolutely. And he talks about minimizing iatrogenic trauma, which, I gotta be honest, I had to look up.
Yeah, it's a mouthful, isn't it?
It's like The trauma from the treatment itself.
Exactly. You're trying to fix them, but you got to be careful you're not making it worse. It's a balance.
Thinking long-term, not just patching them up.
Exactly. And that kind of leads us to what he talks about with the future of trauma. It's wild.
Yeah, like telemedicine and all that.
A surgeon right there guiding someone through a procedure, but they're miles away. It could change everything.
Especially, like you said, for folks who are out there, no hospital nearby.
Exactly. But I gotta say, it makes you think, what if the internet's down?
Right. Or like who's making the calls? It's complicated.
It doesn't give you all the answers, but he makes you think. And that's what a good book does, right?
It does. So look, if you want to know what happens when things go really wrong, if you've ever been curious about those critical moments, you gotta check out Dr. Ahmed's book. Even though it's from the future, it's still relevant today.
It's a fascinating look at what it takes to be a trauma surgeon, what they face every day. It's intense for sure, but honestly, it's a page turner.